Hello, good morning, Nigeria, and good day. Hello, good morning. Can you hear me? Can we hear ourselves this morning? Hello, good morning. Good morning. I'm sorry for coming on and off. Good day, everybody, and good morning, Nigeria. I welcome you to today's session of MEHID-Africa. My name is Olotu Osagyodua, and I'll be your anchor person for this morning before we start the events for the day. I'd like to remind us that we have daily readings, and those readings have been sent to our email. So please log on to your email and retrieve the reading for this morning. Today's reading, today's reading is we have two readings for this morning, and the first one is a document by ECOWAS on their integrated e-health solutions. It's a public-private partnership between the Republic of Cote d'Ivoire and the United States of America-led consortium. The other reading for today is the applicability of the 5 case model to African e-health investment decisions. It's a document prepared by Sean Broomhead, Maurice Mars, Richard Scott, and Tom Jones. It's available on the BMS Health Service Research Open Access. So please download these documents and go through them. These readings we have are just to enable us get acquainted with issues and policies concerning e-health, so we are brought up to speed. Thank you for joining us.
direct our noble cause, and guide our leaders right, help our youths the truth to know, in love and honesty to grow and live in just and true. Great lofty heights attain to build a nation where peace and justice shall reign.
Good day and welcome back. That was our opening for the day. It is the second stanza of the Nigerian national anthem. I'd like to remind us that our daily readings are sent to our mail for us to acquaint ourselves with issues concerning e-health and e-health policies and frameworks and whatever it is that will bring us up to speed on e-health. Today's reading are two, and one of them is the applicability of the 5 case model to African e-health investment decisions. It is in the BMC Health Services Research Journal, and the document prepared by Sean Broomhead, Maurice Mars, Richard Scott, and Tom Jones. The other document is titled is an ECOWAS integrated e-health care solution, and it's a book, a public-private partnership between the Republic of the Government of Cote d'Ivoire and the United States of America-led consortium. It would be great if we can acquaint ourselves with these readings so we'll be brought up to speed. And if there are any questions from any of the readings we've had from Monday till today, it will also be great to have them brought forward for discussions later in the presentation. Welcome once again to day 6 of MEHID-Africa 2021. We'll be joining you by 9:30 a.m. for our first main event for the day, which is a project presentation My eye, I highlight those. Welcome back and good day, everyone. This is day 6. In a few minutes, we'll be getting down to the business of the day right now. And to take us through today's project is Professor Omohwa Adeleye. Over to you, Prof.
Good morning, distinguished ladies and gentlemen. It's my uncommon pleasure to welcome you to MEHID-Africa 2021, Day 6. We have the privilege of having in our midst so many distinguished persons. These are leaders of industries at different ends, and we are happy to welcome you all. Today we have 2 project presentations as already announced. And we have in our midst already our presenters. Promote evening. Have you promoted evening? Okay, we're happy to have in our midst this morning Evelyn Castle. I'm going to share with us very briefly some information about her so we know who is addressing us. Evelyn Castle, I have had to learn to pronounce her name, and I have 7 different pronunciations, but I wish I could do it the way she does. Hopefully she'll do it in a moment. But let me call her Evelyn for my convenience. Evelyn is a citizen of the United States of America. She read health sciences at the University of California, Santa Cruz, and Weldon University. Growing up, Evelyn wanted to be a marine biologist and attended a shark camp. Her favorite place is the beach. Going to Nigeria was the first time she left the United States. Evelyn is currently Executive Director and co-founder at MEHID-Africa. She is board chair and co-founder at MEHID-Africa Clinics. Evelyn is an impact investor, a social entrepreneur. She co-founded MEHID-Africa in 2009. That's about 12 years ago. As executive director, Evelyn provides executive management for the entire organization, as well as programmatic and strategic leadership in the framework of MEHID-Africa's business development and relationship building. She further heads MEHID-Africa's office in Sierra Leone and provides thought leadership for MEHID-Africa's strategic capacity building. She has over 10 years of public health and healthcare related experience in both governmental and non-governmental organizations. Experience also she has in building and overseeing multicultural, multinational teams of 300 to 1,000 public health professionals and volunteers on complex projects and in emergency situations, including live virus outbreaks. She has a background building senior level partner relationships with major global foundations and non-governmental organizations, including Gates Foundation, United States Agency for International Development, United Nations Foundations, World Health Organization, UNICEF, as well as high net worth private donors and managing stringent compliance with subsequent grants. Evelyn's efforts were key to raising over 35 million US dollars in funding over eHealth Africa's first 4 years. In 2014-2015, Evelyn led eHealth Africa to triple staff capacity in 12 months and oversaw the organizational development of eHealth Africa's expansion from 1 country to 4 countries, including staff organization, restructuring, and program development. Evelyn has received a number of awards, including an honorable mention at the UC Berkeley's Big Ideas Competition for Technology in Interest of Society, and a first place award with Rick Hooper's Scholarship Foundation in her thesis, looking at women's human rights and access to healthcare in Muslim societies of northern Nigeria. Prior to founding eHealth Africa, Evelyn acted as fellow of the Global Information Program at the University of California, Santa Cruz. She is a venture investor in early and growth stage African companies that have women in leadership roles and are ready to change the world. She's a very frequent speaker on impact investing, gender investing, social impact, and today we have the uncommon privilege to have MEHID-Africa in the list of the places where she's going to express herself so powerfully. You're very welcome, Evelyn Castle, and it's my pleasure to meet you here.
Thank you so much for that. That was a very nice, very detailed introduction.
You have the floor, please.
Great. So I will share my screen if the presenter will allow me to.
Yes, please carry on. Do just that.
It is saying you cannot start screen share while the other participant is sharing.
He has difficulty sharing the screen.
There we go.
Okay. All right. Wow.
All right. Are you able to see my screen okay?
Yes, we can.
Perfect. Wonderful. So good morning to everybody. Thank you so much for having me, and thank you for joining on a Saturday morning. I wanted to start by saying a congratulations to the University of Benin for hosting such an important event. And I also want to say, thank you to the hosts, Vice Chancellor, Professor Salami, and Chief Medical Director, Professor Abeski. And then, of course, thank you again to Professor Adile for such a wonderful introduction, and then for organizing this conference. It's a pleasure to be here this morning. So I won't do another introduction, but again, my name is Evelyn Castle. Here's my social media handles. If you're able to get in touch with me, I would love to connect with all of you as well. So to kind of start off, I wanted to give a little bit of an introduction as to why we started eHealth Africa and some of our experience working and living in Nigeria. So I came to Nigeria in 2009 for an internship, and that internship was really to start looking at how we could use eHealth and mHealth tools in low resource settings. And if you remember, 12 years ago, eHealth and mHealth were fairly new terms, not really just in Africa, but really globally. I was posted to a primary healthcare center in Kaduna, and originally the conversation was around, could we do some sort of like SMS-based solution for that PHC? But, really quickly, we realized that, the same sort of tools that would be helpful in a PHC in the US are going to be helpful for a PHC in Kaduna, Nigeria. And really what the clinic needed was a more advanced electronic medical record system. And, I find it really interesting because, 12 years ago, and even a lot of the conversation today is around this idea that somehow, Africa's not ready for the same sort of technology solutions that are needed in the US, or somehow we have to come up with different technologies. But, I'm a big advocate to say that, the tools that are needed in the US or in London are the exact same tools that are needed in Africa. Medicine is medicine. It doesn't really matter where you are in the world. The same tools are going to be effective no matter what. But I would say that there's a little bit of a different challenge in Nigeria with implementing those tools because of some of the infrastructure challenges. So obviously everybody here knows, without having consistent electricity, having slow internet or, expensive internet, those are some of the challenges with implementing health informatics tools. But that doesn't mean that the health informatics tools that we're implementing are not going to be the same that you should be getting everywhere else in the world. So we ended up implementing an open source electronic medical record system called OpenMRS. And we trained the health records staff how to use the tool for child immunization so that they could enter in all of the children information who received immunizations, routine immunizations. And some of the impact that we saw immediately from that was the improvement in the monthly reporting. It used to take them days just to calculate how many immunizations they had given each month. Now this was done at a push of a button. So the impact on time saved to do that and accuracy of calculation was huge. Another really great benefit was that they could easily find a child's record when a mother had misplaced it, or if the physical record had gotten ruined somehow. And the impact of that is that we're able to actually immunize children, fully if we know what their immunization record history is. So that was really a great impact that electronic medical record system was able to have. And those were some of the things that we thought we were going to see. But then we did end up seeing things that an impact that we had no idea were going to come up. So one of the interesting things that happened was, to put it in a very polite way, there had been some sort of financial mishandlings that were happening at the clinic. And because now we knew, how many women were coming in and what they were purchasing, we were able to identify that some of those funds were no longer at the clinic. And we're able to make sure that the funds were actually being used at the health facility, which was, a great advantage, obviously, for that facility. So after that experience, we decided to start eHealth-Africa as a nonprofit organization. And really what came out of that kind of initial project was this idea, again, that we can implement state-of-the-art technology in Nigeria. There's no reason that we need to come up with new tools or new technology, or some reason that Africa is not ready for the same type of technology that we use in other countries. But when we're implementing those technologies, we need to address the underlying challenges like access to power, access to internet, so that technology can actually be implemented effectively. So that's kind of how we came up with eHealth-Africa. And then, during our time running eHealth-Africa, we started to get a little bit frustrated with some of the challenges that we were seeing in primary care. eHealth-Africa is a public health organization. So at our NGO, we're not providing any sort of medical care. But, it doesn't really matter. We were still seeing all of these challenges in the primary care field. Our staff, our friends, they just weren't getting the type of care that we felt they needed. And that we didn't feel like they were getting quality care. And so eventually we got a little bit just fed up, and we said, we know how to use technology to improve healthcare. We know how to do the operations. We know how to manage a team. So in 2018, we founded and decided to launch EHA Clinics. And EHA Clinics is a for-profit primary care provider And really, at EHA clinics, we put an emphasis on using state-of-the-art medical devices and health informatics tools to provide the best possible primary care. So why am I talking to you today? So I was asked by Dr. Adile to inspire and empower participants to embark on small and large-scale projects in e-health and health informatics in their respective areas. And I don't know if this is very inspirational, but I am here to tell you that if you want to be successful in the medical fields, that means you need to be using e-health and health informatics solutions. This is not something that is optional or advanced or something that is only done, in the US or in Europe. Like I said before, the same technology, the same tools that are useful and needed in the US are useful and needed here. There might just be some extra challenges around the implementation of those technologies or tools, but there's no difference in the types of tools that are being used. E-health and mHealth solutions are already being adopted at an incredibly quick pace in Nigeria as we speak. So, this kind of like technology revolution in healthcare is already here. And now, we just all need to make sure that we're on board and we're running alongside this. So although that might not be the most inspirational quote, what I am hoping to do today is to just get you excited about the possibilities of health informatics projects. And I want to show you some of the more interesting health informatics projects that we've been able to do at both MEHID-Africa and at EHA clinics, just to show you some practical ways that health informatics are already being used in Nigeria. So we'll start with MEHID-Africa, which again is a public health NGO. Our mission is to build stronger health systems through the design and implementation of data-driven solutions that respond to local needs and provide underserved communities with tools to lead healthier lives. Currently, we have about 300 staff. We are a USA nonprofit, but our headquarters is here in Nigeria. We're based in Kano, and then we also have an office in Abuja as well. And then we work across mostly West Africa, but across Africa in general. And really the kind of three linchpins of what we do as an organization is first around technology. So really looking at how to implement, like I said, state-of-the-art data analytics and information technologies in our healthcare projects. We really focus on large-scale implementation. Obviously Nigeria is huge. Whenever you talk about implementing a project in Nigeria, the scale is massive, and you have to be good at managing large teams across large locations. And you need to have the logistics and the supply chain in order to be able to do that effectively. And then last but not least, it's about the integration of data for informed decision-making. So it's not just about collecting data or implementing a project. It's about how do you collect data, gain insights from that data, and then use that insight to improve the execution of your projects. And it's important that you do this through the life cycle of a project, not just at the beginning, because you obviously learn so much along the way, and you need to be continually gaining insights and modifying your approach to be more effective. So one of the first projects I'll start with that I think is really interesting is our EIDSR project. And what that stands for is Electronic Integrated Disease Surveillance and Reporting Tool. And so this project was designed and implemented during the Ebola outbreak in 2015. And, one of the biggest issues and why the Ebola outbreak got so big originally was because the time it took to identify that the outbreak had started and to when people actually started taking notice and trying to stop it, it was already way too late. Months had passed. since the first cases had entered or had started. And so the outbreak was already across multiple countries, and it was incredibly hard at that point to manage. So the goal of the EIDSR project was to say, how do we make sure this doesn't happen again? How do we detect a deadly disease before it turns into an outbreak? Obviously, if you see an Ebola patient in a rural location on day one and notify, the national authorities, you can send a team to that location, you can quarantine the people, you can treat the patient, and you can stop an outbreak before it happens. If you wait until a week later, or God forbid, a month later, that's way too late. You've already lost your shot at containing an outbreak, and now you're already way behind the curve. So the tool that we implemented was built off of the DHIS2 system, which I'm sure all of you have heard about. It was a mobile DHIS2 app. And again, a mobile app is a tool that can be used anywhere in the world. We use them, on a daily basis, obviously. So there's nothing necessarily about this tool that was, I would say, like super innovative. The only thing that we had to look at was a couple challenges in the location that we were implementing this. Was that, we needed to make sure that the app could send via SMS, not just via internet, because a lot of the locations and the health facilities that this was being deployed in didn't have internet, period, or didn't have very good access to internet. And the other change that we had to make for this app to really make it work in Africa was that we needed to program the app so that it would send as soon as the phone got connectivity. And the health worker didn't have to sit there and kind of like keep pushing the button to try to send it whenever it got connectivity. Because a lot of the health facilities that we were working in, didn't necessarily have even cell phone connectivity. So basically we wanted to know that if a health worker got on a motorbike and was driving between the health facility and their home, and somewhere along that route, they got phone connectivity, the app would just send the SMS at that point, and to make sure that that data was being sent quickly and easily. So that's one project. The next project is the VaxTrack project. And so interestingly, this is a child immunization register. It's very similar to what we did in 2009. But basically, this is just better technology. It had a better user interface. It was a little bit easier to use. It worked on tablets. So it was just a little bit of a better built system. But one of the kind of unique things that we had to manage was the fact that most of the women that were coming into the clinics to immunize their children didn't have a unique identifier. So obviously, like in the US, we would have something like a social security number that is a unique identifier that everybody gets. And so if you go to a health facility, you can give them that number and they can pull up your record. And now, it's great because Nigeria is rolling out the NIMC number, which will serve as the same thing. So hopefully in the next few years, we're going to see health workers and health facilities start asking for the NIMC number. And that's going to be, a unique identifier that can help track you and track your health record across facilities and across the span of your life. But until that is really fully rolled out, we had to say, okay, how can we actually track and identify these women on a regular basis? And so what we ended up doing was saying, let's use biometrics. We would register women with their fingerprint so that if they lost their ID card or it got destroyed somehow, we could use the mother's fingerprint to bring up the child's immunization record. Another project to highlight is the Grid 3 project. And I bring this one up because at the face of this, it might not really seem like a health informatics project at first. Basically, what the project was to collect geographic data across the country. So the goal was really to map all of Nigeria. But even though that might not seem like a health informatics project at first, geographical data is an incredibly important piece of information that you need when making decisions. A person showing up to a health facility with an unusual set of symptoms might not seem like a big deal if it's one case at one health facility. But if you have 20 people showing up in the same general location, all displaying the same set of unusual symptoms, that should set off alarm bells that something is happening, and we need to look and see what is going on in these locations. So geographically looking at disease outbreaks is important, and you need a baseline set of data in order to do that. The other reason why this type of data is necessary is for planning. If a state is planning to build a new health facility, where should that facility be built? The logical answer obviously is it should be built where there's a gap in services. But how do you know where that is? Without accurate maps to show you where settlements are or how many people are living in a certain location, then you're really just guessing. And at this point in time, there's no reason that we should be making big health decisions based on guesses. We should be making them based on data and based on information. So 5 years ago, when we started this project, the mapping of the country was still fairly poor. Really only major cities were mapped. And so the decision was made that it was necessary to actually map the whole country so that health leaders could really have the data that they need in order to make better decisions for public health. So those were just a couple examples of kind of how we're using health informatics on the public health side of things. And now I want to move over to the clinical side of EHA clinics and how we use health informatics solutions in primary care. And I think this might be where maybe more of this audience is interested. And so I really want to just emphasize again that, this is happening now. This is happening in Nigeria. This isn't the future. This is today. And so we really need to be making sure that that we're holding our primary care providers to this level of care. This is basic health services that need to be provided. So the first one, that I want to emphasize is the electronic medical record system. And we made it a point that we did not launch EHA clinics without already having our electronic medical record system functional and ready to go. Because primary care is about treating the person, not just the symptoms. And this means that if you're going to do this effectively, you need to know a person's history. You need to know about that person's family. You need to know their medical past. And really the only way to do this effectively is to have a good data system to collect that information. It's impossible to do this without that. And, it is my firm belief that you should never see a doctor anymore without a tablet or a computer or a phone in front of them, ever. There's no way for a doctor to really provide you with comprehensive primary care without a data tool behind them. And, I want to emphasize that I know that, not every health facility or place of work at this point has a robust electronic medical record system that's standardized in their facility. But I still don't think that for us as individuals and as for professionals in the healthcare field, I feel like we need to take the onus on ourselves to say that this is what is quality care, and it is my responsibility to be providing that care to my patients or to my, my facility. And so I think that, it's really on us to find and to start implementing solutions that are at least a stopgap while our institutions get up to speed in implementing some of these tools. So, there's free resources out there. All of us obviously have phones, we have laptops. We should be the leaders in this and insisting that we are using technology to be better healthcare professionals. And I can guarantee you that if you take the initiative and you do this, your colleagues, your bosses, they're going to take notice. And, you could be the reason that kind of helps push your institution to start to modernize and to start to use, more modern tools like electronic medical records, because this is medicine today. This is not the future. This is basic care and basic tools for primary care. I also wanted to highlight telemedicine. To me, if we're gonna talk about getting quality care across Africa or across Nigeria, the only way to do that is through telemedicine. Fundamentally, there are just not enough doctors and medical staff produced in Nigeria each year to take care of everybody. And most of these medical staff that we do have are concentrated in the major cities. So that leaves our rural locations with, few or even in a lot of times no health workers. And so to me, telemedicine is the best way that we can get qualified health workers to support the Nigerian population and, make sure that access and that right to healthcare is available not just for people located in cities, but also it's available to people in rural areas. And so the technology is here. That's not really a question anymore. The technology is available. It's really just about using it at this point. So at EHA clinics, we subscribe to a telemedicine platform, and that platform is partnered with a hospital network in India. And the really great thing about that is that we're able to get specialty consultations for our medical staff. So if they need a specialist to take a second look at an X-ray or take a second look at a case file, we can have some specialties that maybe are more difficult to find here in Nigeria, have a second look at those medical cases. And then even we can provide one-on-one consultations for our staff with doctors based in India as well. And, India, I think, is a great, India, and there's a lot of other countries similar that are great options for telemedicine, because they are very educated, have good education systems there. They have an abundance of doctors, but it's still very reasonably priced. So the average Nigerian can afford these types of services. It's not just something that, only the richest of the rich people can do. So telemedicine, to me, I think is really, is how we're going to see access to proper healthcare services be achieved in this country. And the other piece of telemedicine that I think is really interesting and that we've seen across the world is how important telemedicine is when we see pandemics like COVID. And I think they were saying that some of the statistics show that telemedicine in the US have increased by 50% in the last year because of COVID. And I know we don't have the data in Nigeria, but if anybody's been on Instagram or on Facebook, you see all of the health facilities here are now offering telemedicine consultations. And this is super amazing. So telemedicine doesn't have to just be done for, doctors or medical personnel living abroad, providing specialty or providing care to Nigerians. This can be telemedicine from Nigerians, just providing it for a more convenient, safer way for other Nigerians. At EHA clinics, we have a COVID treatment center on our facility, and we do home care as well for COVID patients. In the in-house facility, though, one of the things that we do is we hook up the patients to monitors, which are viewed in a central command area, which is what you see in the picture on the left there. And one of the biggest issues and concerns that we had with even starting this COVID treatment center was the health and safety of our staff. And so being able to, the majority of the time, monitor our COVID patients' vital signs electronically, so that we can reduce the amount of times that our doctors have to go into the rooms, and reduce the amount of time that they have to be in the room with the patients, is just keeping our doctors safer. Of course, we're not saying that, we shouldn't be, seeing our COVID patients or like giving them care, but making sure that we're doing it in a way where we're not rushing into those locations and having our doctors put themselves at risk when it comes to donning and doffing their PPE equipment is incredibly important, because, one small slip of forgetting to put on your mask properly or your gloves properly or whatever could lead to an entire outbreak in your entire facility, which would be devastating. So making sure that we're using telemedicine, not just to provide home care or things abroad, but even within the facility is a really great opportunity to keep our patients and our staff safe. The other thing is like, of course, this also allows us to monitor our patients at home. For most of the COVID patients that we had, they were mild cases, and we just wanted to do vitals monitoring for them at home. And so we were able to provide them with the devices. They call us, they check in and tell us what their vital signs are multiple times a day. And then if we see them start to decline, we can send a doctor out to them, or we can ask them to come into the facility. But this, it's not just helpful for the doctors, it's helpful for the patients. They can manage themselves at home in the comfort of their own home. And obviously that's much cheaper than having to be in a facility, but still with the safety and knowledge that they're being watched after and that they're, being taken care of. So, to kind of close out the conversation, how do you build a successful career in health informatics? So, like I said before, my opinion is that, in any career in healthcare at this point, it means you need to be educated on health informatics. Whether that's a public health job, looking at, being like project managers or data analysts or M&E specialists, you need to have a basic understanding of health informatics. And then of course, even more so in, healthcare provision, if you're any sort of medical care provider or health administrator, all of that, you need to have a basic understanding of health informatics and healthcare technology. And again, just to really emphasize, the technology and the tools that we have today are producing tons of data constantly. But, it's really up to you to actually use that data, analyze that data, and then make decisions based off of the data. And this is the really hard part. This is the informatics part. This is what's going to put you above the rest of your colleagues, and this is what's going to make you a leader in your field. Anyone can be taught how to enter data into a computer, but a real health informatics leader is going to think critically and say to themselves, what is that data telling me? How can I use that data to improve the outcome of this patient or improve the outcome of this project that I'm working on? So I really encourage all of you to really just start. You don't need a degree in informatics. You don't need to take a class on data analytics. I mean, these are always great things to do, of course, but you know, the best way to learn is really to just do it. And like I said, you know, these things are already in Nigeria. The onus is on you. The onus is on you to make a change in the healthcare field in Nigeria and start to elevate the quality of care that we're providing to the Nigerian people. So with that, I want to say again a huge thank you for asking me to speak today, and I would love to answer any questions.
Great, very great indeed. In fact, I almost forgot that I was anchoring this program. I thought I was participating like everyone else. When I got in contact with Evelyn for this program, I didn't expect anything close to what I'm hearing today and what I'm seeing today. And Evelyn, I must say, big thank you. Your lecture, your presentation is a huge eye-opener. Yes, I expected a lot from you, but this goes far beyond what I expected. And what I'm seeing here is that we need to engage you again. This is what you've done looks like a summary to me. I could see behind your pictures that a lot is going on that we don't even know about. I must say a big thank you for making a big difference. I noticed that when Evelyn was delivering, early enough, she used the word we in Nigeria, we in Nigeria. And you would wonder, when did Evelyn become a Nigerian? Was it in 1990? Was it when she was born? Was it when she thought of coming to Nigeria? And why did she choose Nigeria to do her internship anyway? She hasn't told us that yet, but we're happy today that we have a Nigerian in our midst who sees things with the eyes of Nigeria. We appreciate you so much. I listened carefully to know whether you had a clear understanding of the infrastructural gaps. Not because, well, it's so, of course, we know it's so commonly said, infrastructural gap, infrastructure. What does that mean in everyday practice? When you gave that illustration of a man on a bike going home and then receives a message at a point where internet connectivity comes on, that at that point, I knew you knew what we were experiencing here. You're really a Nigerian. So thank you very, very much. I have some quotable quotes from you. I'm going to quote you to say some very powerful things. If you want to be successful in medical practice, you have to be using e-health and health informatics solutions. And I just thought of it for a moment. Wait a minute, that means that if any doctor is talking of practice now in Nigeria and is not skilled in health informatics and e-health, is far behind time. I also noted that you said very clearly that we're not here talking about the future, it's here now. Those are very strong statements, and it makes me have to sit up to say, okay, then we need a program of advocacy, very strong and consistent advocacy to the highest level and to the lowest level. And that means a huge lot to me. And I was just thinking, as if you knew my thoughts, how do we get the training? How do we get the certificates? How do we get the that? And Evelyn just hit me hard and said, listen, all those are good ideas, but you just don't have to get those things. As if she was listening to my heart. You don't have to get those things to know how to practice. And she said that in a big way, the best way to learn is just do it. Wow, very strong statement. She also said, this is my opinion, that you should never see a doctor anymore without a tablet in their hand or a device for managing data. That's not the future, it's now. So I have to start rethinking the way I practice in my department among my colleagues who think that I'm doing something wonderful, something great by using health informatics, e-health devices, e-health solutions. I have to make it clear to everybody that that's what we all ought to be doing. It's not something so special, so unique. It's just normal. Anything different from that, it's less than normal. That's what I'm getting from Evelyn. I can't thank you enough, Evelyn. You have really, really changed my perspective. It's one thing to see these things as what we need to pursue in future as part of our future. It's a totally different thing to understand that it is the present that we have not yet actualized, and we ought to be urgent about it. Thank you very much indeed. I sure will be in touch with you again and again and again. Now, I have a few notes here. Someone's saying, thanks, Evelyn. That's Lola Ivado, whom I happen to know to be an NGO women leader specialist who does a lot of charity work to support women in poor communities in Nigeria and beyond, even other West African countries. And then she says, thanks, Evelyn. Really inspiring and easy to follow for a non-medic like myself. We'll explore further. And when she says she will explore further, I know she means it. Someone else says, lovely, cohesive presentation. Yes, I can't agree less. It's so sound. This is how a lecture should be delivered. I think I should simply start calling her Professor Evelyn Castle. All right, thank you. Yeah, so I guess there'll be more remarks with time. But are there questions? If anyone wants to ask, please feel free to ask. But if you have comments to make, please feel very, very free. We'll be happy to admit you. Someone says here, Festus Ojedo, while I appreciate Evelyn, I as well thank Professor Adele for exposing it more to our levels. Okay, fine, thank you. Joanna Abiola, she's from the UK. Yes, she's a gynecologist in England. And she says inspiring and very useful ideas. Yes. Clement Isibo, a doctor, says, great presentation, Evelyn. All right, so Joanna is asking a question that comes up at a family level. And she's saying, how will this work for those in lower income families? Maybe Evelyn would like to talk about that. Yes.
Yeah, I would love to. So I think that there's kind of like two sides to that question. You know, the first one is in healthcare provision. So as either primary care or in public health campaigns, you know, I think the onus is on us to not treat, you know, what we would call like low income families any different than how we would treat, you know, high income families. Everybody deserves access to the same type of care. And in order to provide quality care, you need to be using these different types of health informatics or, like, you know, healthcare technologies. And I think that, you know, today we have all of the tools that are necessary. We have mobile, tons of mobile devices that can run off batteries. So if you're doing community health, you can go into the community with all of these devices and provide that to people in their homes or to people in more rural areas that you don't have like a high functioning hospital or something that people have to come to. So I think that the onus is on us to find the ways to deliver that same quality of care at the rural level. And, you know, when it comes to like lower income families, you know, I also understand, I just feel like what we were talking about 10 years ago is just not what we're talking about today. I know a lot of people who are lower income people who all have smartphones, who are, you know, very tech savvy, who have just as much skill as all of us in accessing care via mobile phones and data. So I think that it's on us about how to engage them better. And I can only imagine how far we've come in 10 years. You know, in the next 10 years, I'm sure that's not going to be really a problem anymore.
All right, that's great. That's great. It's great hearing you. I was waiting to hear you talk about people having mobile phones, and that even summarizes it all. You have a mobile phone, you can take a selfie, you can send text messages, receive messages, do so many things. Why not? Of course, that means that you have what it takes. So please, let's feel very much at home to know that even at home in remote villages, we can still achieve a huge lot. It's all about taking things seriously. It's about policies and practices having to deliver care to people. Everyone deserves the same type of care. Evelyn Castle says again. It shows that these are things that have been running in her mind for so long. I so much cherish your words, Evelyn. So let's look at someone else saying something very important here. So judging by the challenges of recharging phones by the populace, and since there are no community or location-based Wi-Fi facilities, you think telemedicine could be enhanced? Also, yes, the internet has facilitated this conference and enhanced e-learning since the advent of COVID-19. Medical education has now been revolutionized. But the key question here is, with the gap in electricity supply, how successful can we be in telemedicine practice?
Yeah, and that's, I think, a good question, and still something that we need to find maybe a more holistic approach to, I guess, to really target more of like the poorest of the poor. But again, Nigeria isn't unique in some of these challenges. You know, India also had a lot of the same challenges, but the government did step in and start to do things like put some of these high bandwidth internet facilities at some of the more rural health facilities so that they could do things like the telemedicine consultations with the doctors in a more rural or in a more urban location. So I do think that, yes, you're right. There is going to have to be some onus on government to provide these services for the poorest of the poor. But I do think that if we want to try to have the biggest impact the fastest in Nigeria, you know, we do probably need to just target the lower middle class, not the poorest of the poor, because they do have the capacity to buy data to have some of these conversations on their mobile phone, on their smartphone. They can use WhatsApp to send pictures, like Dr. Adile said, take pictures of issues that they have, send it to a doctor where they can consult back to each other. So from the private healthcare side, I would say, you know, if we're going to see big improvements in healthcare in Nigeria, we should focus on the lower middle class and up, and let the NGOs and some of the government sponsored activities focus on the poorest of the poor, so that they can, again, just so that we can have the biggest impact as a country.
Thank you very much. Thank you very, very much. Any more questions or comments? Okay, there are questions waiting for attention. Can we get a copy of the presentation? That's Martin Adu, and I think he's speaking from, remind me the country now. Could that be, well, I'll remember very soon, but definitely Europe. He's speaking from Europe, I remember that. Iriagbo Sel Saibovo is here with us in Benin, and she's saying, although Evelyn says we need not bother about certifications, I would like to ask what she considers relevant curriculum content for health informatics for doctors. Okay, that's for you, Evelyn.
I don't really know. I would say, and like, this is where I would say I'm not necessarily Nigerian in the fact that like I am a much bigger proponent on somebody showing me that they can have the skill versus needing to have the degree. I will say I dropped out of college to move to Nigeria. So I obviously am more on the side of doing is best. So it's hard for me to say, and to be completely honest, I don't know necessarily what is available in Nigeria at the moment when it comes to what type of health informatics courses there are out there. Actually, Professor, you might be better to kind of to help guide on that side. But I do know that there's tons of online courses and trainings that you can take from some of the medical device providers about how to use the tools, what tools are available, and you can do that. You can do all of that via e-learning. So I would encourage you again obviously it depends on what field you're in and what some of your specialties are, but the content is out there. You just have to look for it online.
All right, that's great. That's where the world is going, really. It's not so much about paper qualification. It's about what you can do. And how do you get to learn to do it? Just do it. That's great. All right. Deborah Ehinze is a medical doctor. She has a postgraduate and doing further postgraduate work in public health. And she says, brilliant presentation, very lucid. That's great. I agree with you completely. Martin O'Hara is also a public health physician based in Nigeria. He's a health manager and provides strategic direction for a specialist hospital in Benin City, Edo State, Nigeria. He says, thanks, Evelyn, splendid presentation. You sounded more Nigerian than I imagined. Do you have a certification program for us to access as soon as possible?
Unfortunately, that's not quite what we do. So no, I don't have any sort of like training curriculum for health informatics. But like I said, there are lots of those out there online, and I think it's just for us to find the ones that are relevant to us.
Okay, I'm going to ask you this, Evelyn. This man is talking with you. If I say I'm coming over to you in Kano or Abuja, wherever you are, and I want to be your student, will you drive me away? Will you send me back?
It kind of depends on what type of student you want to be.
An internship, just to run an internship with you.
It depends. I mean, we have the nonprofit MEHID-Africa, and if you're looking at the public health side of things and you really want to get more into the public health world, we definitely have internships at MEHID-Africa that we provide. So please do reach out from that side of things. From EHA clinics, it's still technically a startup. We really only have 3 facilities right now. So we have 2 in Kano and 1 in Abuja. But it's definitely still a startup company. And so we don't really have like a established internship program at this point. But I would encourage you, if you are, health informatics is a huge part of what we do. So if that's something that you're interested in, I would definitely ask you to apply online because we're growing quite quickly. And we will be hiring people, as we start to expand. And we are hoping, within the year to start expanding to southern Nigeria as well. So even though we might not be hiring now, please do send your CV and we can have you on standby.
Right, so that's a great announcement. I deliberately put in that question so people can get to know what opportunities are available. eHealth-Africa is going very, very fast. And one of the questions I've been asking myself is, how does Evelyn cope with this growth rate? Because it's quite dramatic. The growth is in terms of infrastructure. I can see the facilities you put up there in your clinics, in terms of staff strength, in terms of mobilizing funds, and so on and so forth. What's special about Evelyn that's making things happen unusually?
So I would say nothing is special about me. You know,
Mhm.
one of the reasons why we chose Nigeria and why I think that we've been so successful in Nigeria is because there's so much talent here. You know, when I was working in some of the other West African countries, you know, I was bringing my Nigerian staff to those countries because the talent here is just amazing. And we see that kind of over and over again. I don't think that we would be able to grow as fast as we have been able to, or that we can scale like we're doing now if we didn't have the talent in Nigeria. It would be, if we had to bring in foreigners, it would be way too expensive. They wouldn't know the cultural context, any of these things. So the fact that, you know, that we have not just the educated and intelligent people in Nigeria, but you know, we have people who are motivated, who want to learn new things. The fact that you all joined on a Saturday morning to this call, I think is proof enough that Nigeria is a leader in this field, and Nigeria is a leader in Africa, in the health informatics space. And I'm sure that, you know, eHealth Africa and anybody else in this industry is going to grow quickly here.
Thank you very much indeed. Yeah, so that gives us real good hope. We need to, the onus is on us to respond to the expectations of the growing masses. People want health. People want to be well. They don't necessarily want to be subjected to the stress of having to run to hospitals, to clinics, wait for 3 hours to see a doctor and all that. They just want to be well, and it's a matter of right. And the onus is on us, the private sector, the public sector, wherever we are, to do whatever we have to do to meet these needs. Right, somebody here says, thank you, Evelyn, Olakanmi Olagbegi. I'm not sure where this person is based. Thank you, Evelyn, for the presentation. There is a problem with broadband penetration across 774 local government areas in Nigeria. Wouldn't this affect deployment and acceptance of solutions? I'm saying this because I heard you say that we are ready for this in Nigeria. Evelyn?
Yeah, so I think I get frustrated sometimes when we always put like these things of like, well, Nigeria can't do this because of this reason, or Nigeria is not ready for this reason. I don't think that that's true. You know, the whole country doesn't have to be at the same place for us to start deploying some of these tools. And even if you look at like America, there's a lot of America that doesn't have access to high-speed broadband in a lot of like the rural areas, but you don't see the rest of the country waiting to implement these new technologies because there are some places who maybe can't access these services. You know, we are ready in Nigeria, and we need to start now and push. And in a few years, you know, 5-10 years, I'm sure there will be broadband access available in a lot of these locations. And again, you can't go from 0 to 100, you know, overnight. It's a gradual increase. So I think, you know, we just got to go for it. We just got to start and go from there. You're on mute, Doctor. Doctor, you're on mute.
Thank you very much. Yes, Martin Adu is based in the Netherlands. He's given us that information. Now, Kingsley Okafo is a public health physician specialist in epidemiology or statistics. He's been involved in disease control programs in different parts of Nigeria. He's also interested in ethics, and he's asking what ethical issues can arise from e-health practice. Evelyn, are you comfortable with that? Would you like to tell us something? Ethics?
Yeah, I mean, this is definitely a touchy subject, I know, for a lot of people, and rightfully so. You know, there have definitely been some major ethical issues in the medical community in Nigeria over the years, and so I completely understand the concern here. And I think that, like, you know, we just have to be careful to walk a little bit of a line between, you know, stopping medical advancements and the use of these informatics tools and making sure that we're doing it in an ethical way that is monitoring the patients. And I would say, I don't think very many countries have done this well. You know, I would say the US has a ton of challenges because of all of the restrictions that they have put on the medical community when it comes to the HIPAA, like data security challenges. It's kind of stifled a lot of the medical community when it comes to implementing some of these tools. At the same time, we've seen some huge security breaches across the world, which has led towards, you know, Europe implementing the GDPR regulations around data security. And this isn't obviously just in the medical community. This is for everything, everybody's personal data. So it's definitely a tough, like a gray area and a tough line to walk between how do we encourage innovation and adoption, but making sure that we're keeping people's information safe. And it's something that we're all going to have to watch and be cognizant of in the future. So I apologize. I don't have a great answer for you other than this is something that we're going to continue to have to deal with.
Thank you very much. I think he just wanted to know your perspective. It's a growing conversation globally. That's very clear. In fact, in the design of technology, these ethical issues must always come to play. And designers, again and again, have to be reminded that in the way they design, they must pay some attention to how to ensure data protection, and that those who are unauthorized to have access to data should not have access to data. There are issues of data ownership, data portability, and so on and so forth. But again, we don't have to have answers to all of these to do what we have to do. I'm talking like Evelyn now. Yes, Iraku says, drawing attention to a point, that she's clarifying her point, her earlier point. She's talking about designing training for staff in University of Benin Teaching Hospital. That's fine. That's an in-house thing that will evolve with time. I must say here that this has been a process in Benin, if I must chip in something. About 10 years ago, maybe a little less, I introduced health informatics and e-health in our master's degree program in public health in the University of Benin. My idea there was not about having the degree, but that anyone who's a specialist in public health ought to have some skills in health informatics and e-health. There's just no excuse about that. So I just thought that we should start from what we knew. And I called one or two colleagues from computer science, from education. We put our heads together and we started teaching something. So today, in our program, in the master's degree, we have e-health and health informatics. And we start by teaching people how to use their phones and connect them with ongoing health projects where they can learn how M-Health is put into practice, and some skills are picked along the line. We can always do better. At the clinical level, in the teaching hospital, of course, we'll have to do a lot more. The current chief medical director has strong passion for e-health and health informatics. We have fiber optics laid across different parts of University of Benin Teaching Hospital, one of the few of such facilities in Nigeria, and we have so many automations coming up now. Paperwork is becoming less and less visible in UBTH. Every clinic has a computer, virtually every clinic, very few exceptions. So the general practice clinic and the ONG, all those consultations are electronic and people come, but we can still improve. A lot of networking is going on. We have the pharmacy, in the entire pharmacy department wired up as one unit. So you can be before one computer and see what's going on elsewhere. The chief medical director, right in his office, can tell how many patients have visited each clinic at any particular time. It's real time. He knows what's going on in the lab. He knows how much revenue has been collected at a particular time. And that has a lot to do with being able to manage integrity and prevent fraud and ensure there is efficiency in the system. There are cameras in many places monitoring people to ensure that they are on duty. So these are basic things we're talking about. It's more of the practice. Whatever extra training is needed, of course, can be organized by what we have in-house. Who knows? One day, Evelyn may have to come to Benin to to strengthen our capacity. I really love what you're doing, Evelyn. Thank you very much for being a good Nigerian. Something more. Primary Hinze is saying this. Primary healthcare means that holistic care is able to get to individuals and communities and families, irrespective of disparities in geographical locations. I recall how difficult it was to connect online when I had my rural health practice in a small but popular community in Esako. Well, that's Ogona. That's the name of the community. This becomes more challenging when Central Electronic Medical Record Database can allow patients access care wherever they may be in Nigeria. And healthcare workers can access patient records. What can local communities do? Even though we say maybe even though we focus on low to medium income class people, can health insurance systems somehow bridge this gap for the poorest of the poor? That's a lot for you to chew, Evelyn. Should I leave you at the mercy of these questions, or should I pick them out one by one?
I think I can do
Let's
it.
take them out one by one. So, all right, fine, great.
So I would say, yes, I agree with you. Some of the challenges around implementing some of these electronic medical records databases is that they need a lot of internet. And so if you are in a location that has poor internet quality, you're not going to be able to use that technology. But this is kind of where I'm talking about saying that we do, even though an EMR is an EMR, and we do need to modify the technology slightly so that they can be implemented and used in low resource settings. So, there are electronic medical record systems that can work offline and synchronize only when they have access to internet. So you could do something where you're only synchronizing once a day at night. And so during the daytime, when you're trying to use the system, it's not slowed down because you don't have access to internet. So I do think the choice of what technology you are implementing is incredibly important, because I might choose a different technology because I'm sitting here in Abuja, because I know I have access to internet, than what I would suggest you choose in a rural location in Edo State. So technology choices is very important. And it's hard to say, but I mean, for the local communities and what local communities can do, I still think that infrastructure is the biggest challenge for implementing a lot of these things. So, being able to support a health facility with power, whether that's through solar or through, through generator, or even small things that you wouldn't necessarily think about, like security, making sure that a health facility has security so that if you do invest in computers or tablets, they're not going to get stolen in the evening time. Stuff like that is just, it makes a difference and is really important. And then, of course, obviously the internet. I don't know so much about the health insurance systems in Nigeria. I mean, I know about the private health insurance systems. I wouldn't say that I've had the best experience with those, but I know that the National Health Insurance Scheme has been doing some interesting things, and maybe that's an opportunity. But I don't know. It would be kind of hard to say, should we use money from the health insurance scheme to pay for internet? that might be kind of a hard sell when really they should be focusing on healthcare and, you know, providing drugs and care to people. So it's a difficult question.
Well, that's you even went beyond what I could have answered. I'm just wondering here. Well, it's a whole complex of so many issues, but I can't in any way give up Evelyn's statement. We don't have to have all these things in place before we have to do what we have to do. Just do it. And yes, we can. We should go beyond excuses. We should just move on. We don't have to focus on the poorest of the poor, she said. We can deal with the low, middle income class and then move from there. We don't have to have all this. No country has all the solutions before they do what they have to do. Just do it. Right. So anonymous attendee who says, she says, or he says, great presentation. Can you share eHealth Africa contact? I can tell you straight away, just go to their website, eHealth Africa. Google that, enter the website. You have a lot of information, a lot of access opportunities to reach eHealth Africa. So that's not a problem at all. Did I answer correctly?
Yes.
All right. Someone here says that's Faith. Oh, Faith and Moses Peterson. This is from the US. They are both based in the US. How do we ensure electrical consistency for the telemedicine to be effective and uninterrupted? Is Evelyn an expert in providing electricity? Maybe she'll tell us how she's done that in her local environment to make things work in eHealth Africa clinics.
Yeah, I mean, this is kind of a hard question. I mean, I do think, though, that there's a lot of government schemes and NGO schemes that are targeting this. You know, I know that the World Bank is working on a rural electrification project, and they have targeted health facilities. I get questions all the time about, you know, can you provide us with a list of health facilities that don't have access to power? And people are trying to get power out to those health facilities. So I know it's a priority for the government. I know it's a priority for NGOs. And, you know, and there's obviously a lot of options now with the solar options becoming cheaper and more available in Nigeria. So it's, yeah, I mean, unfortunately, there isn't like unfortunately, we just kind of have to wait for some of these schemes to be put out there to see if they actually increase the availability of that. Or we have to donate to our local health facilities. I don't know what else to do, but.
Well, thank you very much. Evelyn won't provide solutions to our electricity problems. We just have to do that. She's already a part of us, so she's finding her own solutions within her own space. We must find our solutions within our own spaces too. We won't solve Evelyn's problems. Evelyn will solve our problems either. But we just solve one another's problems at the end of the day. So thank you so much, Nicole Osaji says. Nicole Osaji is an obstetrician gynecologist. She says, thank you so much for the edifying presentation. In addition, providing a youth center where internet services with computers may be helpful. Furthermore, limiting unauthorized access can be enhanced by continuous reminders to authorized users to log off daily. That's true, very true. Oh, fine, that's fine. So we have we have attended to all the questions that I know of. Does anyone have any other? Is somebody else coming on? So much clarity, Evelyn. I wasn't even sure we'd be able to understand you initially. I wasn't sure you were able to speak the same way we speak. you have learned to speak your English in a slightly different way over time, having spent plenty of time in Nigeria. And it's very easy to understand you. You choose your words very well, you pronounce them very clearly, and you're so Nigerian. We really, really cherish you. You must be getting to know that not many people really know what you've been doing. When I got to see you on LinkedIn some years back, I had in fact created a group on LinkedIn called eHealth Africa. And when I now saw a group called eHealth Africa, I almost shut down mine. And so, what? Somebody else is eHealth Africa somewhere. Unknown to me, eHealth Africa is right here in Nigeria. And I got to now start reading about Evelyn and seeing her projects in different parts of Africa. I was so impressed. And with this program, I just told myself that I either have Evelyn or I don't have anyone. It took me months to be able to reach Evelyn. Surprisingly, she's such a simple person, so easily accessed and very approachable. I called her, she answered so happily. I was very impressed. Evelyn, you're a good example to follow. You set a very high standard for us to get to high only because we're used to the comfort of being below. You have told us some strong statements today. You've assured us that it's not so hard if we mean business, if we sit up and use the opportunities we have without waiting for everything to be in place. Lola Ivano is adding a statement here. My education on skills, the education on skills acquisition and appreciation should start early in primary schools. Very true. In fact, we dealt with that during one of the symposia. Someone spoke from the angle of education, from, in fact, kindergarten. That was what we said. Yes, you're very correct. It might interest you to know that in Edo State, Nigeria, by design, public school teachers use tablets. So the scheme of work, the curriculum, the data on students, they are all captured there. So every teacher holds that and is able to communicate electronically. So we have made some advances at the level of teachers, but we need to make that come down to the level of pupils so that they can become familiar with electronic means of communicating. Of course, what we learn in one sector is transferable to another sector. When children learn in electronic means, they tend to carry it on to the different businesses they go into. And I think that's the key lesson that Lola Irado is bringing in here. She says we need to move away from acquisition of qualifications just for the sake of it. Yes, that means that we need results, not just paper qualifications. Thank you very much indeed. I think so much we have, okay, so I think somebody has something. All right. All right, I think we're done. Once again, thank you very much. Evelyn, everything that has a beginning has an end. For me, if we had our way, we should just go on this way all day. But I can tell, you don't need to tell me there are things you're waiting to hurry back to get back on now. And I'm really surprised that you're able to create the time. We are very grateful for the sacrifice you've made. We look forward to better times with you. I promise you, I will disturb you. I will take your time. Thank you very much. Please be available. I'll appeal very strongly to you. Please, people might get in touch with you hereafter. People want to be mentored. A few people have told me one or two things already. So please try find some time out of your extremely busy schedule to do some mentoring for them. I know you're already doing that, but please do more. Thank you very much.
Thank you so much, Professor. It was lovely to get to speak with you. It's amazing what you're doing. You're a leader in the field. I really congratulate you on everything. And thank you everybody that joined the call today as well. And I'm more than happy to chat with you in the future. So thank you.
Thank you. Goodbye. Okay, so we have had such a pleasant moment. There can't be a better Saturday for me. As it is now, we are going on break. Our schedule says 11 a.m. So we'll go on break for 30 minutes. That takes us to 11:30. We have 5 minutes extra since we closed a little earlier. At 11:30, we are coming back on to engage Prince Nasiru Iharu, the head department of ICT, National Health Insurance Scheme. He's going to capture all of this in the context of health insurance, and he's going to do a lot of work there, telling us the projects that are going on and how successful they've been. He'll also be telling us how much backbone can be provided for health informatics in Nigeria, cutting across healthcare providers that are within the National Health Insurance Schemes, working with the different health maintenance organizations across Nigeria. It's a big network that's been set up, and the very man behind it is going to tell us how far and how well. So don't miss it. 11:30, we'll be back here. Thank you very much. Enjoy your break. Good morning once more. Welcome to this session. We had an earlier session this morning in which we looked at the eHealth-Africa project that was handled by Evelyn Castle, and she did a great job. We're on now for the next session. In a moment, we shall be introducing the speaker. Let's quickly resolve one or two technical things to be sure we're fully on. All right, we're on. Once again, you're welcome. Our speaker is ready, Nasiru Iharo, and he's about to take us on a trip into his multiple projects. It's many projects in one. We shall be introducing him right away. So as you can see on your screen, Nasiru Iharo is already with us. And I shall go on right away to introduce him. Nasiru Saliu Iharo is a prince of one of the kingdoms in northern part of Edo State. He is the general manager and head of the Department of Information and Communication Technology, National Health Insurance Scheme. Before his promotion to this position, he served as Lagos Zonal Coordinator and Benin Zonal Coordinator under the scheme. Prince Iharo is a member representing National Health Insurance Scheme, the Governing Council of the National Identity Management Commission. He's the chairman of the Technical Working Group on Health Information Exchange for eHealth Nigeria. He is a member of the Digital Transformation Technical Working Group for Nigeria. He is a member of the Presidential Subcommittee on Citizen Data Harmonization. And he was also a member of the National Technical Working Group, National Nigeria Vision 2020, ICT thematic area. Before joining NHIS, Prince Iharo was a technology manager at the DAR Diversified Incorporated United States of America, a network engineer with Wells Fargo Bank, North America, a technology associate with Infinity Consulting Incorporated, United States of America, and a creative director, Interface Promotions Limited, Lagos, Nigeria. He's a recipient of the Merit Award of the Healthcare Provider Association of Nigeria, 2015. He is a fellow of the Computer Forensics Institute, Nigeria, member Nigeria Institute of Management, and fellow member Nigeria Computer Society, member Computer Professionals Registration Council of Nigeria, member National Black MBA Association Incorporated of North America. He has had extensive training in health insurance and health informatics, locally and abroad. He attended Federal Government College, Kano, 1975 to 1980. He's also a graduate of the University of Ife, 1980 to 1985, with a degree in building. He has MBAs in computer information system and in telecommunications management at the Golden Gate University, San Francisco, California. Prince Ikaro is from Auchi, Edo State, and is married with 4 children. Prince Ikaro, indeed you're a prince. You've conquered the terrain of your operational fields. You're welcome. Your topic today is the electronic management system that deals with, the topic is Electronic National Health Insurance Scheme Project. And you're going to be taking us on that trip right away. You have the floor.
Thank you very much, Prof. That was a very elaborate introduction. And I'm privileged to be here among this global webinar group to take you through what we are doing at the National Health Insurance Scheme in terms of the electronic ENHIS projects and the roadmap, so that we can have this information at the back of our in order of our various engagements, either with government or in our private life, to know that there's something really going on in the health insurance space in terms of automation and several other activities we are doing to ensure that we achieve universal health coverage in Nigeria. So the National Health Insurance Scheme was established by the federal government to ensure that as long as you are a Nigerian, you should be able to have access to good quality and affordable healthcare in Nigeria. Now, everybody pretty much know or is aware that the NHIS has a mandate, and the mandate is to achieve universal health coverage. Well, what people don't know is that NHIS is also to develop and maintain a national health data bank for the country towards attainment of health information exchange. So with those two related mandates, NHIS has undergone some projects that will make the agency to achieve the mandate it has been given by the federal government. I will go through the individual project as we go along in this presentation, but we all agree that it is practically impossible for NHIS to achieve its mandate, or even for us to achieve universal health coverage in the country without some form of automation going on across the stakeholdership from NHIS and the rest of the participants in the industry, the HMOs, the healthcare providers, and also the state health insurance agencies that have just come up. It's also necessary for me to inform us that national health insurance implementation in the country has now been decentralized, and roles have been given to the various stakeholders. NHIS, for instance, is to ensure that not just the federal employees that are in the country are covered, but also some other companies that have a national spread, and instead of them having unique health insurance from state to state, they can come to the national and take one health insurance policy that covers their employees across the country. So if you're a multinational and you have representations in all the states, it is more feasible for you to come to NHIS and then get your workers and your workers covered. So in terms of the overview of the projects, we are looking at automating the health insurance business process of NHIS, and we'll look at what constitutes that particular project. The core health insurance business process of NHIS involves enrollment and all that, but we'll look at the various modules that is there. Also, part of this project is for us to connect the various stakeholders. We need to connect the state health insurance agencies that are now part of the health insurance implementation process. We need to connect the HMOs. We need to connect the healthcare providers so that we can aggregate data in order for us to meet that health information exchange project mandate of the NHIS. We need to aggregate data. We need to do analytics on them. Another part of that project is for us to at least have some form of call management system, because in our claims management, and complaints management, we expect that our enrollees will be calling, they will be calling to NHIS and lay their complaints and they get resolved. So then, of course, there's ID card that is involved. We have to produce ID cards for our enrollees. The objectives of these projects is, one, to achieve health insurance business automation for efficiency and effectiveness. It is also for us to ensure that health data is aggregated for business intelligence, so that we can have electronic medical record of the individual, of all our enrollees. Right now, the various healthcare facilities across the country, they have their own EMRs, okay? So, but they are not portable. So when we now have this central EMR, which we are deriving from the Health Information Exchange, then when our enrollees go from state to state or from location to location, they should be able to have access to healthcare with their health data following them. Okay, just like MTN, anywhere you go, your health record should be following you. The other objective is to achieve best practice in service delivery so that our enrollees can have total positive experience when they access care. The other objective is, again, like we said, is to achieve our main mandate, which is universal health coverage for the country in record time. Also, as we operate and implement, we want the system to be transparent. We want everybody to be accountable. Why are we going E at this time? Why are we going electronic? It's not a new concept, it's been on ground, but we are going electronic because NHI started way back in 1997, and then 2005, we did the formal sector ruling. And since then, we've been designing all forms of programs in order for us to ensure that all Nigerians are under health insurance. But all that we have been doing in batch processing that is very ineffective. Fragmented data everywhere. There were duplications in our database because you don't have unique identification, just like you have the national identity number. That was not being used. There was inadequate and incorrect data submission from our primary healthcare providers because we need to have encounter data. When our release go to healthcare facilities, they need to have encounter data. And we need to port that. Then we will do analytics on them in order to present either health indices for decision support or at least for intervention by the various stakeholders and government. So there was inadequate checks and balances in the system in terms of payment mechanism, whether it is capitation payment or fee for service. We didn't have access to real-time data in order for us to check who is paying or who is not paying, so that there will be no hitches in access to care by our enrollees. poor service delivery by our healthcare providers are not being checked. We didn't have real-time access to that to know if a particular facility is shortchanging or in terms of healthcare access of our enrollees, and in order for us to intervene quickly so that, again, our enrollees can have total positive experience. Low IT inclusion is what has been causing that in the scheme. There were nothing automated, everything was batch. You can imagine enrollments were done in the states across the country in flat files, in physical hard files. You bring that to headquarters, then you scan them through using OCR, you do QR, all kind of processes, wasted a lot of time. And before somebody can get in, it takes months. And our enrollees were not happy. And then, of course, low coverage, 50 million at this time, less than 50 million in 15 years of our operation, since we started the formal sector. So then something needs to really change in order for us to be able to cover over 200 million Nigerians in record time. So, like we said, the effects of all those anomalies that were in the system were absence of integration. There are no interoperability. Data was sitting in silos, whether it is HMO, healthcare providers. There is no aggregation of this data in order for us to do analytics and then present real-time information for digital support for the country. Inefficiency, the NHIS ecosystem, no automation, okay? Lack of transparency and accountability was there. Lack of critical data for M&E, okay? Dissatisfied enrollees because we are not keeping our promise in terms of not just good quality, access to good quality care, but also there was a lot of delays in accessing that care. So, in terms of strategic roadmap of the overall vision of this project, NHI is seeking to achieve sustainable development goals, SDGs, for health and welfare by attaining universal health coverage in Nigeria in record time. We have adopted a 3-point agenda for that. There's value reorientation of our staff across board. Transparency and accountability is where the ENHIS actually sits on, because it will really bring visibility to the entire operations of the scheme and within the health insurance ecosystem. Then we have also introduced what they call health insurance under one roof. Health insurance under one roof actually means that we have now decentralized, and not just decentralizing, every participant in the stakeholdership knows exactly what their responsibilities are, and there's no more conflict. State insurance agencies know that they have to cover their own employees in the state service, and also the vulnerable group within them. And then the federal knows we're only to cover federal employees, and then those multinational corporations who have offices across the country. And then we now do some other interventions. We raise funds, and then we can now use that to cross-subsidize what the states are doing, and so that there will be overall access to healthcare for every part of the population. Our IT response to all that is to have a very simple, secured, scalable, coordinated, connected technology platform for improving the effectiveness and efficiency of the health insurance ecosystem. Now, for us to achieve that, we have partnered with one of our federal technology agency, NICOSAT. NICOSAT is partnering with us on this implementation because they'll be able to give us a proof of concept that they have what it takes in order for us to pull through this very important project. I also need to let you know that this project has been classified as a national critical infrastructure of the country, and so agencies are coming with us. NIDA, they're also on board, NIMSI is on board, in order for us to pull this project off as our own, and in order for us to achieve the objectives of the project. In terms of other collateral benefits, we believe that when we deploy these projects, there will be job creation opportunities. We are looking at over 10,000 new ICT-related jobs to be created through the hiring of data entry clerks across healthcare facilities, state insurance agencies, even HMOs, and all that. Also, we are looking at about 500 new ICT-related high-skill jobs, because now you're going to be looking for like system administrators. We're going to be looking at data analytics, analysts, and all that. Security is part of it, cybersecurity experts, software developers. Of course, that one is we're already seeing the evolution of that. Then we believe that job creation will, of course, reduce poverty and help some of our social problems that we have right now. The big picture, again, is for us to not just automate, but to aggregate all health data across the country. Counter data will be collected from healthcare facilities. Enrollment into health insurance will be collected from states to HMOs across the country, and we will end up with an national electronic medical record of the individual so that they can treat. The components of that we will look at in a short while. So design consideration for the project, again, like I said, it has to be simple, it has to be flexible, it has to be cost effective, and security is a very high consideration. We're not just doing encryption, we're also doing authentication. We're making sure that whoever is authorized to see some part of the data is the person that is seeing it. Then it is in compliance with integrated health standards, things like web service. So it's web service based, which means it is platform independent. Whether you are using HP, whether you are using Dell, you are using whatever server you are using, these are applications can run on it without problem. For us to be able to aggregate data from like HMOs and all that, we need to do application program interface deployment. Health level 7 protocols are also part of the compliance. Digital imaging and communication in medicine, like is also considered ICD-10 in order for us to have a unification of disease naming, and so we use the ICD-10 code so that this information can be portable, not just locally, but also internationally. Design adoption is to incorporate analytic tools for effective reporting. Again, we are going to, once we come full stream and we start doing analytics on the data we collect, we are going to be presenting very credible health indices for this country so that it can support effective intervention and people can be well. The various components for the solution platform, that's the software platform that we're using. We've named it HIPAA, which is Health Insurance Business Process Automation. It's a web portal-based platform. The modules include enrollment module, which we already deployed. We're using it now. Right now in NHIS, you no longer have paperwork. Okay, everything is real-time online. And then there's offline if you are going to a remote location to go and do enrollment. You can enroll. When you come back to a point where you have connectivity, you synchronize, and then the data is in the database. So enrollment module is ready to go. We will soon be linking it with NIMSI. We're already sending signals to NIMSI. The servers that will be connected to NIMSI will be dropped at GBB, and from there, we will link up to NIMSI so that we can announce to the country that health insurance unique identification is now based on the need. Once we complete that, early eligibility verification, that is at the point of access to care, is also a module in the software deployment on the platform. Then accreditation management. So our accreditation activities by our staff, when they go to accreditation point, all these are going to be automated real time. Once they access that facility, the various checklists are going to be weighted. And once they finish the accreditation, right there and there, they will get the results and present it to the facility. It's not a matter of going back and assess and come back and report. No, right there, the facility will know why they did not meet the accreditation. And that will be the end of story. Benefit plan management. This is very, very, it's very versatile. Individuals can decide, oh, I don't want to. Once it comes full stream, we'll have standard benefit. If you want the standard benefit, you can take that. But if you don't want if you don't want that standard benefit, and you just want to you want to take malaria and take accident coverage, you want to take you want to pick and choose, you have the capacity to do that. Encounter is when you go to the facility and access to care. So the module is there. We'll collect all that, what we were treated for, what was the diagnosis, and what drugs we were given. All that will be collected from the encounter module. Records management, okay, part of it is lab. Well, if you went to do a lab test, X-ray was taken, scans were taken. That record management module will help us to collect that information. There's complaint management module, okay, that will be taking complaints from our enrollees, even from HMOs, from the general stakeholdership. That will be the interface for the submission. There is service authorization module. That one deals with referrals. So if you come in as a primary, you come in on the primary health care, access to primary health care, and then there is a referral that needs to be done there. Then you will have to we'll have to verify you through this module. Payment module is there. This payment is when the claims have been processed and all that. You use it to make payment. We also use it to pay capitation to the healthcare facilities, so that at the end of the day, we are able to see the fund flow in the system. If HMOs are not paying the capitation, we will see. If they have not paid on the fee for service submission, we will also see. So there will be no more argument, as regulators will see, even the HMOs will see, will have their view under this module. We also have reporting analytics. Like I said, that will allow us to display disease map of the country, dashboards available for the various stakeholders. Then, of course, user management, where we do the logon user management for security purposes. In terms of the project lifecycle, we have passed through analytics, development, and all that. So we are fully at implementation. And then after implementation, we will do evaluation, monitor, and then follow up with maintenance and support. So the individual module, we have monitoring, that's components of the project now. What are the physical infrastructures we are now putting in place in order for us to actualize the ENHIS project? There's a monitoring and control center upgrade that we are doing in one of our location sites. So from there, we'll be able to see our entire network. Like I said, we are connecting our state offices with VPN, virtual private network, dedicated connection. And then we're also sending VPN through fiber and the VSAT to state insurance agencies. State insurance agencies are established by state government, but we want to bring VPN to their server points so that we can connect secure data to our central server, again for analytics and all that. So that project has started. We are now, the physical space has already been prepared, and we are waiting the servers. They are under procurement, and they've already been ordered, and they're coming in. In terms of hosted data center and disaster recovery, we are looking at 3 locations. all within the GBB hosting services. GBB, that's Galaxy Backbone. We know they have a tier 3 setup right now. We will go in there and then use that particular setup to have 3 locations for full redundancy and data disaster recovery. Okay, we'll have our production site, we'll have backup in 2 locations with real-time data replication and synchronization in order to ensure effective integrity, data integrity as we carry out operations. The MPLS, multi-protocol level switching, is a fiber network that that is part of that connectivity. So we are doing fiber, we're also doing VSAT. For areas where the fiber map is not available, we'll deploy full VSAT, but the VSAT itself is also going to be a backup connectivity to areas where you have fiber connectivity. So we also, like I mentioned, the enrollment module, we've gone very far in terms of these the modules that are in the platform, that is the automation platform. We've gone very, very far in them. I can only now tell us the percentage completion that we've done. In terms of the automation, we've gone very far. We're even over 60%, although I stated 60% in this presentation, but we have gone beyond 60% completion, and we've already started deploying the various modules. I told you about the enrollment. Everything now is pretty much automated. Payment and contribution collection is now automated. Connectivity is 90% completed. We have our satellite modems, we have our routers all over the country in our various state assurance agencies and also in our NHIS office locations. The HMOs, the healthcare facilities are going to be connecting through the internet, secured connection to the internet. Okay, in terms of security, even though Galaxy Backbone is providing its own internal security to the data center implementation, we are only doing co-location because we want to have full control in terms of security of the health data. Like I mentioned, we're not doing even private. We're not doing private cloud. We're not doing public cloud because the health data for the country has been classified as a national critical infrastructure because of the information that is there, not just for general public, but also for security agents and all that. So we are having a full dedicated server systems for this very particular project, with us having full control about the security. There will be end-to-end encryption of data, end-to-end encryption. Whether the data is in a flash drive, whether it is in a laptop, whether it is in a tablet, wherever it is, it must be encrypted. It will be encrypted, and then whoever needs to have access to it must have that logon, username, password for them to be able to access that data. That's how serious in terms of the security of this data is concerned. So we are doing co-location with Galaxy. We are not doing private cloud. We are not doing public cloud. We have a dedicated server that has this information. The core management system is in progress because we've ordered the equipment. They are on their way. Once they come, we will have a call center in the central location in Abuja. But if the call comes, there will be a toll-free number, which means the enrollee doesn't pay for calling, either for complaint or to get information. If the call comes to the central switch in Abuja headquarters, if the call came from Lagos and it's identified to come from Lagos, we will route it through our data network through voice over IP to Lagos, and then it will go to agent station, and then Lagos will pick it and treat it locally as a local call. But if it is something they can, if it's just to collect information, Abuja can pretty much provide those information. But if it has to do with access to care and all that, the call will be routed. That's how versatile the core management system will be. In terms of ID card production, we have resumed again. The industry will know that after a while, more than 5 years, we will not produce ID cards for enrollees. But we have come back again with the present leadership of our very able Prof. Professor Nasru Sambo. We've had the delivery of 1.3 million cards, pre-printed cards. There are ID card printers at state insurance agencies. So at the point of enrollment, all you need to do after enrollment, just like you are issuing ATM cards, right there on the spot, we just issue you your card. If you want a physical card, it's fine. The option is for you to have a digital ID. Not everybody knows how that operates. So those who want physical card, we get it. Those who want to be generated their digital IDs will also have that option. In terms of where we are, again, I said, with solution deployment stage. We are training our staff. Where this training has been serious. We are getting some of the best training companies in the world to build capacities of our staff in order for us to effectively support and maintain the ENHIS that we are deploying. I want to stop here. Thank you very much for listening. I'll take your questions. Thank you.
Well, thank you very much indeed. This has been a very technical session, I must remark. And I am really, really impressed that so much is going on in Nigeria. Without this lecture, we would never have known that there's so much going on. I was asking myself at the time, where are we? In fact, even in the presentation, because we're having to share from here, it was difficult to even know where he was, because he was really, really going deeper and deeper. But the good thing was that he was able to deliver it in a way that we're able to appreciate what is going on. And I must thank you very much, Nasiru Ikaro, for being so thorough, being so down to earth. Things like this are things that will inspire the hope of Nigerians, in spite of the present times, the difficulties we are facing economically, and so on and so forth. These are the kinds of critical, like you said, this has been classified as critical infrastructure, which means that the federal government is prioritizing this. It definitely is going to help to deal with a lot of poverty issues directly with health, yes, but it's going to create opportunities for employment, as you have rightly said. And because a huge number of human resources will be involved at lower levels, as the whole system cascades further and further, there will be the need to have robust inputs from human resources to make the system run at healthcare facility level, at HMO level, and at other institutional levels. It means that the infrastructure, the devices and parts that we need will have to be serviced, maintained, if not manufactured in Nigeria. So the economic implications are broad. And what you're describing is a big, big, big project consisting of multiple projects. I must thank you very much for a job well done. This is really impressive. We consider ourselves extremely privileged to have all this information. It's something that's worth studying all over again. You need to go back, and that is the participants now, go back, sit down and study this document in details, because we all have a place in this whole arrangement. And you can see the thoroughness with which it was described, everything in stages, not just some kind of theoretical expressions. You know what comes before what and what comes next. You know how things will flow until we get to the final stage. And we see that happening at different points and in different parts of the project. All right, in case there are questions to ask, we'll be very ready, very willing to ask them. If there are comments, we'll be ready to admit them. But I want to ask this. Shall I call you? Shall I call you Professor Ikaro now? Hello, are you with us?
Yeah, well,
Yeah, because I
that's
think
fine.
you're quite robust in knowledge. I'm not surprised given the your CV. You've studied a lot, you've practiced in a very wide range of areas. You're a security expert by every definition of that word, and you are very capable of communicating at any level with any aspect of ICT deployment. I can see you are, with your background in engineering, you're now into health, you've gone into so many other areas. You're a business expert. In fact, you have not just MBA, but MBAs. So you are a real Nigerian that we can really trust. You are highly resourceful. Given all of these credentials, sir, what is the guarantee that this thing will work? I think that's one question that will be on many people's minds. What's the guarantee that it will
Well,
work?
it's already working. That's the good part of it. It's already working because our enrollees across the country are already accessing this enrollment. Enrollment is very, very key. An enrollee that comes and wants to enroll into the system, they want to be able to enroll and access care as at when due. This has been a major problem. Enrollees comes in, wants to access the enrollment system, and it is batched from our various locations across the country. Before it gets to headquarters, it takes 3 weeks. Before it gets processed, it takes another 2 months. And then before it even gets into the enrollee register, it takes about 6 months. And the enrollee gets frustrated. So now they are seeing that within 72 hours, they are inside the database. So that by itself is already working. The complaints that used to come from enrollees that they are not able, they have been registered for the past several months, they are not on the register. That one has been eliminated completely by this part of the project that we have deployed, which is the enrollment process. Payment.
Sorry, to be sure, are you saying it has been eliminated or it is being eliminated?
It has been eliminated because we already right now, if you want to register into the scheme, there is a web portal. Now, where we are taking the enrollment to in the second phase of that is a self-service in the sense you can from your phone come into the portal and then enroll fully, put your information there, go make your payments on that particular program, and then you submit. You make your submission and you are in. Now, for us to make that happen, that self-service to happen, we need to integrate with NIPSI because there's a key component that will uniquely identify you, which is the national identification number that needs to happen. Now, you cannot just come and put a NIN number in the system and then apply. What we want to be able to do with the application is verification. You put in your NIN number, it goes straight to the NIPSI server and verify you. So there are basic information that will come back from the NIPSI server. And then you cannot change that. You cannot change that. So you just have to now fill your other rest of the information and then you make a payment and you are in. So the first part of it before this integration is already working. We already deployed that. And now payments are done online using various payment gateways to pay for the service. That one is already working. So the connectivity one, like I said, we already, you have the various state insurance agencies and also our NHIS state offices. We already started deploying the fiber connectivity and also the visas. They already been mounted. They already mounted. In fact, yesterday, our verification team had a meeting. By Monday throughout next week, they will verify the entire from across the country, from state to state. They'll go and verify all the installations by our vendors, and then we'll fire up and we are good to go. So it's a project is already, it's already working. I just told you the delivery of the ID cards. We already received them. The machines are being dropped at the state offices for printing. So the issue of those days, we used to print cards at the center, then we carried them to the various MDAs, and then they start distributing. Some they don't even distribute, you know. That one is a thing of the past. As an elderly, you come to our state offices, you do your registration, you get your card, okay? Now, if you are tech savvy, you can be generating your own ID card on your phone and show at the point of care. So those are the options.
Very great. I'm going to read from someone, a Nigerian who is based in the UK. She says, that's Lola Ibadan. She says, thank you, Nasiru Ikaro. The presentation, though very technical, gives one hope for our country, Nigeria. A right time indeed for investors of all descriptions. So she's telling us that your presentation raises hope. As if I knew, that was exactly what I said earlier on. I hadn't read this then. Hope for Nigeria, hope for Nigeria. I also talked about economic implications, which she also has mentioned here. A right time for investors. Investors are attracted into this massive project. And you know, the moment there is a backbone, it's very characteristic of the backbones of any network. Once there's a backbone, new networks come on from there. New networks, necessities generated as solutions are provided, new questions are answered, new challenges are created, and new solutions. It's a continuous network. Once the central backbone is there, and that's just fantastic. And I'm very impressed that it is heavily multi-sectoral. It must have attracted a lot of experts coming together to deal with every aspect of it, not just about networking, data and equipment and the software and co, but the very content is determining the design of the technology. That's what I'm seeing here. And we really pray that as it's a continuous project, I think, as it continues, it will not fall back. I have one question more for you, sir. You mentioned NIGECOMSAT, and you appear to have some presence there too. What can you tell us about NIGECOMSAT as we speak? What does it mean for those who may not know what it stands for? What happened in the past? Some years, some things happened, and it does appear that everything just disappeared. So where are we with NIGECOMSAT? If we don't know much about what happened to it, if it appeared to us as a project that had some questions unanswered, why would we have a national health insurance scheme rely on such a massive question unanswered?
Yes, NIGECOMSAT, Nigerian Communication Satellites Limited, even though it's a government agency, it is a private sector driven concern, Now, what they have done is to form a consortium. Their main focus or their core business process is satellite communications. But what they have done is to form a consortium of very, very reliable companies with various focus, various disciplines. There are those who are into software development. There are those who are into integration, system integration. Some are into networking proper. Some are into security. Some are into, like I mentioned, the ID card production. They are into ID card system and enrollment systems. So they are working with like about 6 companies like that in the consortium. The reason why we at NHIS we are dealing with NIGECOMSAT is the fact that it is a government-to-government relationship. We hold NIGECOMSAT responsible. They did a proof of concept for us across all the project components, and it was a viable POC. And then we now also critically examine the individual companies that are part of the consortium, and we find them to be of industry. They have a remarkable resume in the industry. So, and we have started, and we are beginning to see results, and we are very much involved. Like NHIS, we also have our own internal capacities. In the software development, it is not all Microsoft. Our in-house team programmers are also involved in it. We are the one directing the shape of the solution and the platform and all that. And we're also really involved, physically involved in the programming, day-to-day programming that is involved in developing that solution. So it is, we're interfacing with Microsoft because it's easy for us to work with that kind of a consortium rather than dealing with individuals, one company after the other. It was easy for us to just look at Microsoft and say, okay, you have these consortiums you are using to implement your projects. Let us deal with you on this. We look onto you for this. But at the same time, we also critically scrutinize the various consortium membership for us to pull it off. But it's a government agency, into satellite communications, but they have veered into so many other solution provision, but using renowned companies that are delivering in the technology provider space.
Right. Thank you very much. I think you focus your response to the aspect that interfaces with NHIS. I noticed you were careful about talking about the past, what happened.
Yeah.
Something that disappeared or something. We're not sure. So that's why
they'll be there to explain what disappeared and what appeared. But
all right. So let's leave it that way. You seem to have the benefits you want from them, and because we trust what you have presented, it makes plenty of sense to us. I'm going to read to you what somebody said. Olakomi Olagbegi. I thank the NHIS for the innovative project. I never knew until today that the scheme is aggressively going digital. That speaks of me too. I didn't know until about a month ago. My question is, considering the different EHRs of individual health institutions, is the scheme also considering integrating these different EHRs with a view to having a national EHR system, that is electronic health record system? Is this under consideration, or isn't it feasible? Can you please respond to this, in the light of the statement you made at the beginning that a part of the NHIS mandate is to generate a national database on health, something like that?
Yes, it is compulsory. It is compulsory for all our healthcare providers in the health insurance space for them to submit encounter data of the individual to NHIS. Before now, they were putting it on flat files, physical, and send it to us. And that was not working because it takes a lot of time to input all these data. Some of them are written in bad handwriting and you cannot even scan them. So now we have the platform, the encounter data module that I mentioned in that solution. Every healthcare facility will go and log in, and in their submission of that encounter data, there are fields that they need to fill. They fill all those fields, what the person was treated on, what drugs was provided, if there were X-rays, if there were lab tests, if there were all that. They submit that information. It's compulsory that they submit that information. Even though they are having their own individual EHR at their local level, when they bring all this same information that constitutes that is already resident in their own EHR at their level, when it comes to NHIS, it now forms it now forms a national EHR, a national EHR. That's what we want to achieve, so that if our enrollees, and eventually it's going to be all Nigerians. We use the word enrollees in the health insurance space here, but it is going to be all Nigerians eventually. So that every Nigerian, when you move from Abuja to Ikotekpene, maybe you just treated yesterday, and then you jump on the plane or you go by road, you get to Ikotekpene, you can walk into the facility again to continue your treatment. But the information about your treatment in Abuja will be following you, or follow you to Ikotekpene. So the point is to aggregate all health records of Nigerians into this health information exchange platform, and so that that information can be following you everywhere you go. Yes.
Right. Thank you very much, sir. I think that's very clear. But we also need some clarification here. A lot of changes have occurred in the NHIS in recent years. In fact, the changes are almost continuous. But there is a common complaint that we often don't have access to information on changes in policy and practice. And I think this is an important point you may need to address. The last time I saw the last copy of guideline you have, which is also on your website, that is the NHIS website, is old. Perhaps a decade or so or more ago, it was produced. So each time we go for conferences, meetings with NHIS, could we get to hear of new approaches, new methods? I'm in the management of the University of Benin Teaching Hospital, so that gives me access to some information. But is that the best in the circumstance? Can't we have up-to-date information? For example, reviews have been done in the community-built health insurance scheme, and the way you're designing the ICT just now captures the new approaches in the new designs in NHIS, makes provision for the involvement of states. So to be able to do that, the decentralization you talked about has been captured, but much of this cannot be seen in your guidelines. Can we, in the process, while also digitizing your processes and your business processes and the businesses of other stakeholders, what about in-house guidelines to inform the general public, especially the users of your services? Can't we have them updated?
Yeah, there are several guidelines for each of our various projects. And then we'll have a master guideline for the whole NHIS operations. That national guideline derived from our law, okay? And then there are now guidelines for the various programs that we are running, like the basic healthcare provision has its own guideline. The gift ship we have just launched has it as a group, individual, family, social health insurance program we've launched has its own guideline and all that. These documents are available individually on our website. But the national guideline, which relates to the law that established NHIS, our relationship with our stakeholders, who does what and all that, that is being reviewed because the stakeholders have said there are several things that we need to tweak on it. It is being reviewed, and once they review by the review committee, once that one is done, then we will also publish that to within the stakeholdership. We'll publish that. But right now, we have the various individual program-dependent guidelines. We publish them on our website for people who want to download. Yeah.
All right, thank you very much. So I think that that's clear. But we do. You talked about platforms where persons who may have complaints can express themselves. So please locate those opportunities, and I'm talking now to our participants, and express yourselves. If you have questions to ask, please feel very free. and express yourselves on those ones. And I can promise you, sir, if I get to know of unanswered questions and challenges, I'll get back to you since you are the NHIS that I now know. We appreciate
Okay.
you very
All
much.
right. No problem.
Questions? More questions, some comments? Okay, now anonymous attendee says, as a follow-up to the earlier presentation, primary health care means that holistic care is able to get to individuals and families in communities, irrespective of this disparities in geographical locations. Okay. I recall how difficult it was to connect online. This is the old question repeated. I think the person wants you to also address the question. The summary of the question is, what is there to help rural areas, especially healthcare facilities in rural areas, to benefit from the robust arrangement you have described? Can health insurance systems somehow help to bridge the gap in ICT, particularly in the area of provision of primary medical care for the poorest of the poor? Given that we have a gap in internet connectivity, what can NHIS do perhaps to help to bridge that gap? Is any provision being made for very remote communities, especially those already enrolled in the community-based health insurance scheme?
Now, to answer that,
Ikaro, can you?
like I said, yeah, okay. So to answer that, I want to mention that we have presented, especially for government facilities, primary healthcare centers that are in the remote, very, very remote part of the country. We have approached the Ministry of Communication and Digital Economy in their National Council of Communication that there is a need for them to provide broadband connectivity at primary healthcare centers. That memo was considered and approved, and I think they are at the implementation stage. My communication with the project manager for that, he said right now they are doing training. They will start with training on satellite technology to select or nominated individuals across the country. Then, once they create that awareness, they will now deploy that. In the interim, the way NHIS is working, any healthcare facility that is participating in the National Health Insurance Scheme has access to our capitation. For every enrollee that is registered into the system, there is a capitation we pay to that facility that he has chosen every month. Whether you go there for service or not, the money stays there. Once the number gets to a certain number, we believe that every facility can break even at 500 lives per facility. They will be able to break even. Beyond that, as long as they have a phone set, we believe they should be able to have set some money aside, which we have recommended. They will set some money aside to support technology, to support that connectivity. If they have a phone set, they should have access. That is why the solution we are deploying is web service based. It's platform independent. If they have a phone, whether it's Android or whatever, Windows, they can have access to the internet, buy some data bundle. We're not saying that they should be connected online real time. What we are saying is that as they are gathering this information, they will have an offline input into the application. Once they get connected, that is a synchronization that takes place, and we get that information. So what they will be investing minimally in their various facilities is just to have that connection to export encounter data to the central server. Okay, so that itself is not a problem from our own analysis. at the back end, and also for the kind of money that we are giving to these facilities on a monthly basis. Recall that even those primary care centers that we are talking about, government, the money that NHS is bringing is additional funding to maintain and to ensure there are no out of stock in drugs and to ensure that enrollees get good quality access to care. The what do you call it? The employees of that facility and even the maintenance of that facility, there is another program through the National Primary Care Development Agency that is providing money for the supply side maintenance that has to go on in that primary health care center. So with that, there should be some money that can come out of there for you to be able to buy data bundle and be able to synchronize your data as we need it at the Center for Analytics. Yes.
Great. Thank you very, very much indeed. So I can see it's a very, very comprehensive work you're doing. And one thing running through my mind is this: how are the different departments, units, and even state offices of NHIS able to coordinate all of this? You must all be involved in a lot of continuous communication and training and retraining to be up to date. But this is quite a huge amount of new information coming into the way health insurance is being governed in Nigeria. It speaks to the fact that we have a lot of highly skilled resources here, and that the health insurance scheme is serious about succeeding. And we hope that everything you have said continues to bring about the success that we need. I appreciate you so much. Now, just
I must not leave this presentation without appreciating the new leadership in NHIS. Professor Nasir Mohammed Sambo, to me, or within the scheme, we feel is God sent because he came in and not just adopt ICT as the best thing to happen to NHIS for us to actualize the mandate. He is also deeply involved. He's also deeply involved. And it takes that kind of leadership for us to move so many government projects to the next level and for the benefit of our people. The ENHIS we are deploying now is revolutionary. Just like one of the participants mentioned, it has a trickle-down effect. We only touched or scratched on the surface. Right now, we are seeing young Nigerians who are programmers, system developers, integrators. They are coming and they are bringing presentations. We're even giving them certifications. They are going to developers hospitals, providing these platforms or providing solutions, technology solutions to them. They are going to HMOs and telling them we can develop platform for you to manage care. That is opening up space. Some of them are integrators, those who will be doing API designs, application program interface designs for the various healthcare providers, state HMOs, or even the state insurance agencies. So it is opening up, with this trickle-down effect, it's opening up the space, not just for employment, but also for us to have critical data, real data. We always be talking about lack of data. NHIS is now poised, with this NHIS is poised to provide real critical data that will be necessary for real and credible government intervention for health care service delivery in the entire country, and also real and critical data for even the business, like somebody mentioned, the business community. People can now predict. You can even look at the financial financial implication of it. From this data, we're able to know what is the real healthcare expenditure for the entire country, and this information will be available for the business community for them to make their decisions on which area to invest and what is the new gold mine they need to focus their investments on. So it's very broad, and it has its own trickle-down effect for everybody, the industry, and also for government. Yes.
Right, that's great. Thank you very much indeed. This is really, really a massive project. The Library is saying, for the benefit of lay persons like me, who have limited knowledge of his organization's work, could the speaker please elaborate on the types of external links and opportunities that will enable us get involved? For reference, I am in the community economic development sector. So she is in the community economic development sector. She's involved in social empowerment, community empowerment. So she's asking, from her point of reference, her point of work, how can she get involved in what NHIS is doing?
Yeah, that is good. That's a very good question. If you look at the various programs of NHIS that we have rolled out, for example, we have a revolutionary one that we recently launched, which is called the gift sheet, Group, Individual, and Family Social Health Insurance Program. Group, Individual, and Family Social Health Insurance Program. What does that mean? If you are an individual, if you come into the platform and you say you want to register as an individual, okay, you have the opportunity, you pay 45,000 naira, but with that 45,000 naira a year, you have opportunity to register 2 more people, either you, your wife, you, your husband, and a child, or you, or somebody that is maybe your house help. Okay, 3, which means it is now 15,000 naira per individual for health insurance cover for the entire year. If it is more than 3, it jumps into family. So from 4 to 9 is considered family. 4 to 9. If you are registering 4 to 9 people is considered family, and it's still a 15,000 naira per person. Then if it is above 9 and it's now 10, and 10 to 1 million, 10 to 10 million, 10 to 100 million is group, and it's still 15,000 naira per life per year. Okay, that 15,000 naira allows you to have access to standard care. So what can you do as a business person? You can mobilize the community people as a social mobilizer. You can mobilize the community people to come and have access to this care. You can set up as a program manager, And we're able to considering at NHIS what will be the incentive for people to set up as program manager. The commission that will be involved in that, because we really need to take that gift sheet across the country, because we believe it is a program that will really allow us to achieve universal health coverage in record time. So for investors, they can become program managers and bring people for the commission to enroll into that gift sheet program. Then there are other, like what do you call it, the technology space that I mentioned about. People can come in there and provide technology solution. For example, we say, okay, NIN is now compulsory in the country. NIN is now compulsory. NIN, National ID Management Commission, has now turned that ID generation into what they call the ID ecosystem approach, which means you can come to NIN Center and say, I want to be able to generate NIN for you, for new applicants in the system. They have a certain amount they will pay you. I think for every new registration, it's a $1 equivalent that they will pay the agency that generates that NIN. But you have to apply to them and say you want to do that. But for NHIS coming in and adopting the NIN as a major or a unique identification for its program has actually now blown up that space again for people who want to participate in the ID ecosystem. We're even now approaching drug manufacturers for them to produce unique drugs for the health insurance ecosystem. that conversation is going on. So if you're into drug manufacturing, that's an opportunity. Also, because you now have a serious and critical fund flow to facility level, because the capitation we're paying is going directly to the facility. You can now set up, rather than concentrating at the urban centers, you can now go to your community, as long as the people that are there, because health insurance is becoming compulsory. If health insurance is compulsory, it means that you as an individual, you're either paying for yourself, somebody is paying for you, or government is paying for you. Government has already indicated through the Basic Healthcare Provision Fund, by giving money to NHIS, that we will use to cover the vulnerables, those who cannot be able to pay in the system. The money is already coming in, and we are disbursing through the state insurance agencies, and we are monitoring the fund flow. So because this critical fund is now coming for health insurance cover, it means that establishing facilities, healthcare facilities at those remote locations is a new business. Okay, and you don't have to establish one. You can have in a state. Why don't you move from one community and be establishing primary healthcare centers? I mean, private sector primary healthcare centers. So once you come in, we accredit you into the system that you meet the criteria for primary healthcare provision. We come in, we accredit you, you come into the system, and you become visible for a release to choose. So if in that community you have, let's say for example, 2,000, 5,000 people in that community, and you are the only facility that is available there, capitation will come to you, even if it is across the river, even if it is we go to Ireland, to facilities in Ireland to pay capitation. So that is a big business opportunity for those who want to play in the health insurance space. Plus consulting. Consulting. If I leave NHIS now, I'm going to be into consulting. I'm consulting for health insurance technologies and all that. Okay. It's all right.
I was hoping you were going to use me as an example of consulting. I didn't know you were going to use
it. Exactly. Like you now, like you. Consulting like you. Yeah.
Thank you, sir. Yes, we're really growing as an economy in spite of the difficult times. I think opportunities are still increasing, and we pray that things work out well as we all engage with all seriousness and do play our parts. Somebody has raised an issue here, though you have talked about it briefly now in your answer, making reference to the design of your ENHIS ecosystem, the automation process. The person wants a little more light thrown into the global into the identification, unique identifier system that you talked about, which has a global part. He wants you to throw a little more light into that.
Okay. Right now, there is a government policy, federal government policy, that for any citizen access to social services, the unique identification must be through the national identification number that is managed by NIMSI. It's a regulation of government, and whether you're a private sector individual, whether you're a government individual, if you are into identity management or identity generation, you must be in compliance with NIMSI, and the unique ID number must be the NIN, National Identification Number, generated through NIMSI and managed by NIMSI. So that is being adopted across the board. Within that ID space, that's why you have BVN. BVN has now been integrated with NIN. We at NHIS will integrate by this project before the middle of the year is over. We've already integrated with NIMSI. National Population Commission is integrating with NIMSI. Police are integrating with NIMSI. Federal Road Safety is already on its part. Immigration has already done its own. So all the various identity databases across the country, whether in the private sector or public sector space, they are all going to have to integrate with the National Identification Database and its resident at NIMSI. So with that unique number, because it has to do with biometrics, because before you can generate a national identification number for the individual, you must have taken their 10-finger biometrics prints, okay, fingerprints. You take them in, that is the only thing that would uniquely identify that individual that would enable you to generate a NIN number. So now that we are adopting NIN, it then means that for all the transactions that the individual is doing, whether it is health, whether it is finance, whether it is education, and all that, they are now going to be tied to that unique ID number through the NIN, National Identification Number. So all the databases are now being hooked to it. By the year 2021, the directive is that all the databases, ID databases, should have been integrated with NIMSI. Okay, so it is the NIN, everything will be based on NIN.
Well, this really raises hope. I recall Dr. Kondo Iweala talking many years back about the need for a centralized system for identification of every citizen of Nigeria, within and outside Nigeria. We had hoped that things would move faster, but good things may have problems along the way. Eventually, they come to be if people are serious. I think that with multiple institutions now having to work together and perhaps put some demand upon the National Identity Management Commission, perhaps that's driving some seriousness. We hope it works, and it works very fast. And that the pains that people go through to get their national ID cards will be very quickly resolved. And then, you know, it also has to do with telecommunications. Good enough, you're also an expert in the telecom industry. So the suspension, as it were, of the activities in telecoms industry will also be relieved the moment we're able to sort out the immediate problems. And I do hope that moves very fast. Thank you very much. Ebi Ekura Oluwafemi is a public health specialist and a physician who is interested in rural health. He's asking, how do we get further information on this project? You have done a very big presentation. He wants to know how he can get more information on this project with time. How?
Well, I think if my email is not on that presentation, I'll present it. The presenter will make that available to the disabled. It is pretty much straightforward. NIKHARO at nhis.gov.ng. That's my official email. You can also use Nasiru for us, Nasiru with number 4, then US, Nasiru for us at yahoo.com. With those two emails, you can reach me, a request for further information. And then, of course, my phone number is 080 5679 7316. 080 5679 7316.
All right, this is really impressive, very impressive. So with your permission, I can share this with all persons who have registered for this program. Am I correct?
Yes.
And then they can reach you questions that they may have regarding your presentation.
Yes.
Right, so this has been a very great day, and your presentation very rigorous and very robust. We appreciate you very much. Nasiru Ikaro, very technical, very detailed, and very importantly, it has raised hopes for many people that there is such a massive project going on in Nigeria, and that we are indeed a serious country that can make things happen. Good enough, you have informed us that this is not just about what is going to happen, it is already happening. And like I said, it looks to me like a continuous project. It's not something that will just terminate at any particular point. It is that there are time frames that you're working with, and I like your approach to your presentation. You use a roadmap model so that we can know from time to time where we are, what we have done, what comes next, and then it's easy for people to monitor. Maybe again, we might have some time, if you don't mind, to talk about how to maybe do that for us for a minute. Do you think NHIS, especially with the kind of project it's coming up with, and your very fantastic project, do you think it is gaining sufficient public visibility?
Okay, so we are doing, our executive secretary has used so many fora to let the people know that one of the key deliverables under his tenure is this electronic NHIS, where everything is going to be automated, both in our health insurance business process and even in our own internal processes. We have an ERP project that I didn't mention going because we're talking about health insurance, but the ERP project, which is even customized, is not the off-the-shelf kind of enterprise resource planning thing, but it's a very customized one that ties up our internal processes together, and it ties up all our state agencies, our state offices tied together, so that everything is pretty much electronic, real-time data. Our executive secretary can be somewhere in the world, and he's making a presentation, and he has access. He logs in into his own dashboard, and he has access to real-time data as it's happening. So if he says enrollment is now 25 million, that at that time he's pressing on the dashboard, that is already updated data that is quoting real time. So it is a very robust solution that we are deploying, and the ES is using every forum, I think almost every week, where he's having to address the public. He is always announcing this, that look, NHS is going E. Even the entire stakeholders, we're having a lot of meetings with them, to let them know this is where we are going. We are going to be integrating, and we're already deploying the backbone network and all that. So it's telling the world, and even various development partners are aware of this, and they're all coming and trying to interface with us to see what they can do to help us realize the projects in real time, and so that it can really allow NHIS to meet its mandate of achieving universal health coverage in record time. Yes.
Fantastic. That's great. Thank you very, very much. I wish this could just go on and on and on and on and on. I feel proud to be a Nigerian, having listened to your presentation. And I think I'm not alone. We have hope, and things will get better. I appreciate you so much. Thank you for your time. Thank you for your sacrifice. I made a phone call to you. You never knew me. You believed me. You trusted what we had to do. And today, it's a huge fulfillment. Africa is proud of you. The world is proud of what you're doing, sir. Please keep it going. Thank you very much. We shall keep in touch. So this brings to an end. Thank you, sir. Yeah. This brings to an end the project, special project presentation that we put up for today. And now we're going on break, a lunch break that will end at 2 p.m. And then we shall meet at 2 p.m. to take care of the remaining parts of the day's program. Thank you very much once again, all our resource persons, Evelyn Castle, Nasiru Ikaro, our participants who have been patient and who have been engaging, and those who are viewing from different sites across the world. We appreciate you so, so much. Thank you, and see you later in the afternoon. Goodbye. Good afternoon, ladies and gentlemen. Thank you for being on at this time. This is the last session for the day, and indeed the last session for the conference. Thank you very much for being a part of this. There are some important things that we need to deal with right away, and as we go on, it will begin to add value to what you're doing. May I say here right away, please, that much of what we're going to do now will be interactive. And so I appeal to every one of us to please participate actively, send in your comments, and let us know your thoughts, and let's see what is doable. This section is on embarking on your e-health and health informatics project. Embarking on your e-health and health informatics project. So if you have thoughts to share, please feel free to send your thoughts across. Feel free to share your mind. And let's learn from you. Okay, so you recall that we have had 2 project presentations today. Even before today, we had presentations by different resource persons. The total number of frontline resource persons for this conference comes to 2 for our primary presentations, that is for our keynote speakers. We have 2 keynote speakers. We have 5, we had 5 symposium speakers. That makes 7. And then we had 2 project speakers, making 9. And I have had to deliver some, do some presentations here and there also. That makes 10. So 10 major presentations have occurred. In addition, we have had 15 different participants as panel discussants. 15 panel discussants, 2 of whom, well, I wouldn't say in addition, 2 in addition to the symposium speakers. So 2 panel discussants in 5 places, making 10. So that comes to a total of 20 actually. So let's take it again. The initial line, 10, and then now we talk of 2 in 5 places, making 10 in addition. So 20 resource persons have been engaged, and they have expressed so many things. Each person had a practical thing to present. Given all of these, and as we bring the conference to an end, the question is, what next? What would you now do? What project do you want to set up? That means that we now need to be very practical. We need to look at the future. May I say here that this critical component of the program is an opportunity to look at business. Business here is not only about making money, but by practicing. You would notice that from what the different speakers have done, there are opportunities for investment and opportunities to recoup, opportunities for profit. But the first thing is to identify problems so that we can deliver solutions. Solutions attract business and profit, and more business and more profit. But they all start from understanding that there is a problem. If you look at our program outline, we gave a few instances that you may wish to address at your center. It's policy development and review. This is especially important for those who are in the public sector. So if you're a public sector worker, a doctor, a nurse, or whoever you may be, this is a huge opportunity for you. you can initiate policy development. So if you're not in Nigeria, it already exists. In the event that such a policy does not exist, you can pick up lessons that you have learned from this conference and initiate policy discussions towards policy formulation in your country. But you probably have a policy in your country, you may not be aware of it. So one thing you can do is to study the policy, okay, for your country. Then perhaps you don't have one for your state, or you don't have one for your health facility or such other organization where you are. Policy doesn't mean something fantastic out there in the air. It just means the framework with which you operate. Identify where the needs are, identify what systems can address the need, putting that system together, and engaging with the heads of the institution and other decision makers to adopt such an arrangement as the way to go. That's simply what we mean by policy in very simple terms. So once you can do that, then you have developed a policy for your institution or any of such place that may be of interest to you. The next thing you can do is to have a policy review. In a policy review, you're looking at the existing policy. Let's say for us in Nigeria, there are policies in the health sector, there are policies in the ICT space. The Ministry of Communication handles that. You can sit back and look at the policy, identify its strengths, identify its weaknesses, and then propose some solutions to the respective government agencies to look again at the policies. And then that will help. Perhaps there's a policy that restricts the use of some facilities or some devices are not coming into the country, but for some reasons, that's happening because there's an existing policy that prevents it from coming in, or some other things are there. It could even be a business or importation a rule or regulation that puts restriction in bringing in such an item. You can then make a proposal that this policy is doing harm to e-health and health informatics, and then you're able to make a difference. Policy review is about making a difference, improving on policy content and policy practice or policy implementation in order to bring about improved results. So in your state, there is silence on the use of e-health and health informatics in health facilities. You can actually develop a policy to say that every health facility, whether private or public, in state X should have an electronic means of handling health records. With that kind of policy in place, you can then advise government that in the next 5 years, 7 years, 10 years, as the case may be, there's the need to have a gradual introduction of an electronic health management information system. That is what health informatics is about. So that's a project you may wish to undertake. So all of these that we're discussing are project initiatives that I am proposing to participants. If you have comments to make, if you have questions to ask, objections, reservations, or whatever it is you have in mind, please feel free to share on this. Before we go on to the next item. Let me quickly make a statement here The presentations that have been made in this conference will eventually be available to all. But for now, we want to benefit those who paid for the conference. There are people who paid. They were the ones whom we originally promised that we're going to send the entire program to. So they will have full access to every item there. But for those who are participating free of charge, we will have to find a soft way or a short way to give them some form of access. But you recall that if you have registered, all those who registered before now, even if you did not participate, we have been sending you some readings every day. You have got readings now for 6 days. In fact, the readings for today are in 2 forms, 2 materials in one. So you have a lot of things for you to help guide, support your knowledge base that this conference is already giving to you. So if you have not registered, then that means that you don't have access to the ones that we have given out already. But if you have registered, perhaps you registered late and you did not get what we sent initially, then you can let us know. Those ones are not necessarily the proceedings from this conference, but they are important and useful materials that can help you build your knowledge base and your skills and help you transit from theory to practice in e-health and health informatics. So we are open to questions, comments, and answers before we go on to the next point. Keep in mind that today is for projects. 2 massive projects have already been presented. So here we are looking at possibilities of the kind of project that you can come up with. The next one we want to look at is service delivery. Sometimes people don't quite appreciate how much they already have. What are the materials that you already have? What are the things you already have with which you can make health informatics and e-health happen? The quickest and easiest answer to that is to say that people have their phones. Every person who has a mobile phone has an opportunity to participate in e-health and health informatics. All that's needed is to adapt the phone to the necessary facility or necessary service. So in terms of service delivery, you may wish to undertake a project there. And what's the nature of the project? It is that you identify a service in your health facility and then develop how the service can be better delivered using existing infrastructure. So I'll give you an example. Let's say you are a doctor. Patients have to travel from different places to see you run a clinic. And you know that they don't have to come. But because they want to see you, they have to spend a lot of money traveling. They spend money passing the night, and they have to spend money traveling back. We can benefit from e-health in a special way in such a situation. The first thing is to refer that patient to a healthcare facility that is nearby where there is a doctor. Now that doctor is not you, but what that doctor is to do is to examine the patient, carry out some tests, take a history, do some monitoring in line with the guidelines that you now provide to that doctor. Then the doctor gives a feedback to you through the patient's mobile phone. With that, you capture records on the patient and you keep your records in details. The doctor that has looked at that patient puts down his findings in writing, the history, physical examination, and you're talking with that doctor. So at the end of the day, the patient has saved time, saved money. The money and time that will have been spent traveling and finding accommodation, and the suffering that would have been accompanied, that will have accompanied all those processes, all those would have been bypassed. And that's the beauty of using the establishing a service, taking advantage of e-health, and in this particular case, taking advantage of M-Health. So that's about service delivery. Even within your healthcare system, it is very possible to set up an arrangement whereby you are able to deliver care from a distance. Let's say you're a surgeon, and then you have a patient in the clinic, one of the other doctors in the clinic. It is commonplace for such a doctor to call you as a specialist while you're in theater or just before you go into theater to discuss that patient's case with you. But we can go further from there and using very basic tools available to take some pictures and then we can share. Many cases can be managed from a distance. We can at least make assessments, even if not initiate treatment. We might even initiate treatment. So take a child that has a tonsillitis. A physician might experientially commence treatment, request that some medications will commence, and then until the patient arrives. It can even be life-saving. Sometimes tonsillitis can be so disturbing that it compromises respiration, and it may be severe enough to lead to widespread infection and with some other morbidities, especially if there are comorbidities, comorbidities with it, it can lead to severe complications. So early treatment, early management of cases can be achieved using e-health. So you can set up a service, all right, to support that arrangement. Patients can also send text messages to a dedicated receiver at the healthcare facility. And that receiver can even be a simple telephone. So all patients who have complaints can send in messages by text message, or to even find out whether their appointments are still valid or whether they could come earlier or want to have a change in appointment. Such easy communications can be set up as a special service in your hospital. So that's the kind of thing we want to promote. So with that in place, they're setting up a service. Let's look at another one, deployment and installation. This will particularly interest those who are in the ICT industry, that is engineers and technicians and other people in those fields. You can work hand in hand with the healthcare providers in an institution to determine what types of facilities they would require. Once that is done, working with them closely and the manufacturers and those who know what to do, experts in installation can be approached. You can approach them. And then in a phased manner, using a roadmap, you can begin to develop or deploy equipment that will support e-health and health informatics. These are things that experts need to work on, and there must always be caution to ensure interoperability between the different equipment in place and interoperability between the equipment there and equipment at other levels of health management information system. Interoperability is always an important point to note, so that installments, deployments, and installations do not come to a waste. If the facilities or the hardware that you are using for e-health do not produce the results or the kinds of benefits expected, then resources have been wasted. So that's why technologists, engineers, technicians must always have the know-how on identifying the appropriate infrastructure that can be used for e-health or health informatics in a particular setting. Okay. Of course, the installation will be handled further by experts. Appropriate locational definitions, very important, and ensuring that there is appropriate support infrastructure, such as electricity, internet connectivity, and so on and so forth. And of course, there is the appropriate environment to preserve the equipment. The next one we want to look at is teaching e-health and health informatics, teaching or training. Do you know that having participated in this workshop, you can actually organize workshops? Having participated in this conference, you can organize workshops and seminars, simple training programs, bring in one or two experts to begin to train people on what to do using the existing equipment. I've noticed that there are many facilities that have computers, and the computers are underutilized. They're underutilized because the human resources meant to help people to use those computers are non-existent. Or there may be trainable people on ground, but what to be trained to do and how to use them is a different matter. E-health or health informatics is not something out there in the moon. It's not in the blues. It's not something far-fetched. It's something that we can easily imagine and work on. Let's look at a simple example. Many laptops and desktops come with Microsoft Office package, which then includes Microsoft Excel. Using Excel to save data from time to time and uploading the data to a database can be a very fantastic way to handle what you do. So if every pharmacy unit or every laboratory unit or every part of the health facility you're interested in simply keeps their records in a systematic way and uploads the records in a central system, that is already a training that you can give people to do. Sometimes the training required for e-health and health informatics is not about e-health or health informatics by itself. It could be on how to use a device or a facility, all right, for the purpose of managing health data. Okay, at this point, I want to recognize Dorothy Okpokam. Dorothy, if you have something to say, can you please write it in the chat so that we can read? If you have something to say, please just write it in the chat room. We'll promote you and then we'll allow you to speak. That way we can see you, we can hear you. So once you have raised your hand, we'll recognize that and we'll allow you to speak. If you have questions to ask, please feel free and ask. Okay, so we'll carry on with what we're saying. Okay, we're getting some messages here. They may have passed, but I think it's good to recognize them. Okay, Lolai Vado is saying, well done to all the organizers of the innovative event. Generations to come will surely build on this for a greater Nigeria. Yes, thank you very much. We appreciate you. I think that was when the former speaker, presenter was speaking. All right. Okay, so we shall go on now. Please just raise your hand if you want to say something or send in a message that you want to speak. We'll promote you and allow you to say something. Because like I said before, this is an interactive session. So still talking about projects, you can organize such a thing, write up a small proposal to your head of department or your head of institution, as the case may be. Invite a resource person and do something. Don't think of starting big and then delay yourself. You can start small and grow from where you are. So please feel very free. And let us have projects taking off on health informatics. Okay, the next, yes, so teaching e-health. And the other thing about teaching here is about introducing it into the curriculum of your institution. So if you, let's take a program in nursing. Let's say you're running an RN program in nursing. Even if it is not written in the curriculum, you can strengthen your curriculum locally. So your curriculum may have a place for computer literacy. Maybe your curriculum says so, but does not talk about internet literacy or e-health and health informatics. You can add those things to your curriculum locally. It can just be for one day, and you get somebody who can demonstrate how to use existing technology to deliver support through e-health and health informatics, how to track data and so on and so forth. That can be a lot, that can be a very strong stimulus for students. A training delivered is an opportunity created. All right, another point of interest or project that we can embark upon is business, that is consulting. Now, if you have a long enough experience in e-health and health informatics, it means that you have acquired some skills. It means that you have something to say. E-health and health informatics is a large field, very large field. There are even people whose interest in e-health and health informatics is promotion or advocacy. They are not technical experts in handling the devices or operationalizing the systems, but they are just concerned about advocacy. They are advocating for e-health and health informatics. So you may want to build a business around that. Set up a small group that will advocate for that. Put up posters, put up banners, write up recommendations to government, the executive arm of government, the legislative arm of government, the appropriate ministry involved. When you've started that way, you can share your burden and let people know what you have done. Some funds can come in for that. You can apply for grants based on that experience, and hopefully you get some money to help you go on. That is consulting, or that is a form of business in itself. But if it is a non-governmental organizational arrangement, it becomes non-for-profit. So it all depends on how you want to do it. Your business will be for profit or not for profit. Maybe consulting for profit or not for profit. Whatever it is, it starts by providing solutions. Once you provide solutions, it will bring about financing. You'll be able to get some funding for what you do. Okay? If you want to take it up as a big employment, fine. In that case, you are going for profit. So you may need to engage experts that will be able to work with you if you are just starting, so as to mentor you. By the way, that statement applies to all persons who are just coming in and who may want to learn how to handle consulting when it comes to e-health and health informatics. You need to meet people who are experienced so they can guide you. But there are definitely business opportunities there. There are those who develop apps. There are those who also design devices. There are those who recommend changes in existing apps so that the apps are better able to deliver service or are better adapted to the environment where you intend to use the device or app, as the case may be. All of these are opportunities that we must not waste. Sometimes it may have to do with sales and installation and deployment, may have to do with the business, may have to do with importation, may have to do with logistics, may have to do with maintenance. So many ICT people who are involved in repairs and maintenance of equipment, they want to have additional skills in which they are able to do some maintenance work for some equipment. However, we must keep in mind that equipment maintenance is a skilled job that requires some training and exposure. The reason is that many electronic equipment now do not have parts that are readily repairable. A few may require that you are able to do some minor maintenance works or some minor repairs perhaps, but many of them will require replacement if they are truly, truly bad. Whatever it may be, your knowledge or your skills are required to make such a decision. The last that we want to address quickly is research. You may wish to conduct research. That means you start by having a research question. A research question may be something like, why are health facilities in X state not advocating or not using e-health facilities or e-health solutions? So then that becomes a research question that you would then need to carefully build a study around. That means that you're going to then develop objectives around that. You're going to have to identify the broad scale research problem, and then you justify it. And then a study is commenced. You know you take a decision on who and who to approach and what to do. You may need to interview people, you need to make some observations. There are different ways or approaches to to addressing that research question. And so you put your data together at the end of the day after implementing it, and that gives you research. Research can come in various forms of design. Basic research is very fundamental. It has to do with knowing the physics and the electronics behind equipment and several other matters that may come in. But applied research is then different. You're looking at solutions and how existing knowledge can make things better, or how to inform new knowledge or the need for a new technology or device. All those are possibilities in the context of research. So having said so, those are the things we would want to talk about for the purpose of this. Okay. Somebody has quoted me as saying that a training delivered is an opportunity created. I think that's true. I agree with you, and thank you, Mrs. Osinebo Griffin. That's Mrs. Kende Griffin for saying that. Dorothy Opokam, thank you for your statement. I appreciate you all and commend the good work you're doing. I wish a follow-up of this conference will continue and other institutions will be incorporated into the vision to move the nation forward. Example, universities, hospitals, and states as well. Thank you. All right, thank you. That's a very good recommendation. We're happy to know that many people appreciate what we're doing in this conference. We're happy to know that people see value delivered. And we look forward to being able to meet expectations with time. Okay. Of course, there are many more areas of project opportunities that may arise. You might even want to partner with existing projects. You may hear, for example, that there's a facility or a state that's involved in deployment of e-health facilities or e-health solutions. We want to partner and learn in the process. It's always good to learn by doing. It's a very good thing to undertake. You may also want to go and study what is going on somewhere. A health facility that uses e-health and health informatics solutions can provide a lot of information and skills that you can learn from. So nothing is wasted. Opportunities to learn should never be thrown away. That can be a project of its own, a personal project, a project to learn. Okay. Having said this, we'll go on break very briefly for about 5 minutes, and we shall come back online. But please continue to drop your comments, continue to write down your questions, if any. We shall be back in less than 5 minutes. Right, we are back online. The purpose of this session is to give some general guidelines as to the communique to expect. We intend to develop a communique that will cover many of the issues that we have discussed in this conference, and we shall send it to all participants, and they will make their comments, get back to us, and then we'll produce a final copy. That will then be shared with stakeholders at the highest level so that we can make sense out of this conference and make a difference beyond the immediate impact that it has made on those of us who attended. In a moment, we shall be having someone address us on the draft curriculum. We're not presenting a draft, but we're presenting general guidelines and inputs and contents that we intend to put together in the draft that we shall send to you hereafter.
Good afternoon, sirs and mass. It's about 2:55 p.m. here from where we're presenting. So I'll be presenting a summarized communique for the MEHID-Africa 2021 eHealth Health Informatics Conference. We've had 6 wonderful days of activities. These activities have started on Monday, 15th of March, and today is the last day, 20th Saturday. We looked at readings, we looked at several keynote lectures, and we looked at several symposia. Thereafter, we went on to take a couple of abstract presentations, looked at a couple of documentaries, and then we had special project presentation. The last part, just before I came on, was taken by Professor Moko Adele, where he talked about embarking on your own health informatics project, basically outlining a step-by-step process how you can develop yours and where it's not already in existence or strengthen where prior to was not existent. So we can then see going via all the presentations so far that e-health and health informatics is already being deployed in several hitherto unknown ways already in Africa, even in Nigeria as we speak. I've had several key persons provide key insights and even tease our imaginations on the possibilities that exist with e-health and health informatics. We've identified that several infrastructure will be required for deployment of e-health across the African space. Key roles will be from federal government to state government to local government, and even communities can play their own parts in ensuring e-health. There's necessary infrastructure that needs to be provided. Like we said, not everything can be on ground, but the basic minimum is required to ensure that e-health takes its place as ought to be. Institutions of health education, we've seen them collaborate for an event like this, and we can expect more collaborations between not just health and education institutions, but also institutions that provide information, communication, and technological supports um, um, continent-wise. We also require the federal government to provide overarching umbrella, synchronize data, and maintain databases and mainframes all across national space. We expect that state governments to be able to provide a statewide support for health facilities, even in their day-to-day runnings that often is managed by the local government cadre. Now we expect that there will be logistic support. This will come in form of electricity supply, which has to be constant to ensure that mobile devices, tablets, and even laptops remain charged and can then be used. Internet access will need to be maintained and continuously are supported to ensure that at every point in time there is a connect between the health system, the database where all the information exists, and even the patients themselves as soon as it is required. General support services will also be provided to keep maintaining all of these infrastructure that exists. We need communities to themselves drive development in their own health by taking charge of projects that may already exist and then continue supporting projects that continuously exist. They also need to buy in when projects come in. They also need to buy in when projects come in to ensure that these projects actually follow through and do not suffer stunted growth as ought to be. So far, so good. In the last 5 minutes, I have provided a bird's eye view of all we have done during the process of this conference. MEHID-Africa 2021. The theme was to strengthen health services in Africa. That we have been able to do that in the course of this conference, and we await more input, more discussion on this topic, even beyond this conference. Thank you very much for having followed us through. We're pleased to have you. We hope we have met your expectations, and we also like to provide feedback as necessary. Thank you very much.
We want to appreciate all our participants for remaining online till now. We are bringing the conference to a close in a moment. When this conference started on Monday, we had a welcome session in which we simply made some introductions of what the conference was all about. Then on Tuesday, we had an opening session. We had the opening ceremony where we had two keynote speakers address us. The first keynote speaker, Professor Timito Alonge, talked about the theme itself. And then the second keynote speaker addressed us on driving Africa's development through e-health and health informatics. We had different symposia, each one handling a sub-theme of the conference. The next day, we had 3 more symposia after having 2 the previous day. And on Thursday, that was 2 days ago, we did a detailed review of abstracts that were submitted for this conference. On Friday, yesterday, we looked at documentaries covering the University of Benin Teaching Hospital and University of Benin that are relevant to e-health and health informatics. We also looked at posters of abstracts submitted for other conferences and reviewed them for lessons for anyone who may wish to do a poster on an e-health topic. Today, we have had the uncommon privilege to receive 2 great project leaders in e-health and health informatics. Evelyn Castle told us about eHealth Africa. And then we had Nasiru Iharo, who addressed us about Electronic National Health Insurance Scheme project. And this formed the platform for us to discuss how to have our own individual projects. That way, we have had a robust conference. And like we said, we should work on a communique and send back to all persons who registered for this conference. By the way, we'll have perhaps close to 300 people who registered for the conference. We have not got the last figure yet, but we know it is more than 200 people, maybe up to 300 registered. So as long as you registered, you will get a copy of the communique. But the only people who get the full complements of all the presentations are those who pay the conference fee. As we said before, all persons, whether you paid or not, will get readings for each day. Eventually, we'll be able to upload all the materials for everybody to have access to, but that will be much, much later. The second project presenter, Nasiru Iharo, has graciously made his phone number and email addresses available. We shall also send all these to all the persons who registered for this conference. In the event that you have participated in this conference without registering, we appeal to you to please go online and register. Registration is free of charge. You're not paying for that. It's just for us to have records that you indicated interest in this conference and that you participated in it. And so you are going to have some conference materials. So please register. That's how we'll have access to your email address and we'll be able to send you what we want to send you. At this point, I want to appeal to every participant here You have come across other participants in the course of this conference. You have also had the opportunity to listen to different presenters. All of these provide the robust opportunity to have the contacts of these persons and to be able to build partnerships from there. Life works by partnerships. So please, I enjoin you all to interact with your colleagues, the persons you have reached, new relationships that have been established, and to build on them. Networking is one thing that makes e-health and health informatics work. And that's the best thing that can happen to you if you take it on from here. That's a part of the project orientation that we talked about earlier on. Okay, so we'll expect that you complete your readings for today. We have sent 6 sets of readings already. One more set of reading will come for tomorrow, which strictly speaking is the last day of the conference, that is day 7. We shall not be gathering here, but all that we shall do is send you materials online. And then you'll be able to study them for day 7, which is tomorrow, Sunday, officially the last day of the conference. But we shall bring the conference to closure right away by saying a big thank you to all our resource persons. We had resource persons from United States of America, from Trinidad and Tobago. Some of those resource persons are from Africa. In fact, most resource persons are from different parts of Africa, but that live in different places. We had an American address us today who is based in Nigeria, and of course, very experienced with Nigerian terrain and with the subject matter e-health and health informatics. We have people that have come from different walks of life. Many of our resource persons are not necessarily medical practitioners, but have extensive experience in different technical aspects of health informatics and e-health. We commend you all for the very, very great contributions you have made to developing e-health and health informatics in Africa. Africa will not be the same again because of you. You have made that big difference. This conference is the beginning of greater things to come, and we are confident that we shall rise to heights. And remember what MEHID-Africa means. MEHID-Africa means mainstreaming e-health and health informatics for development in Africa. The development of Africa cannot take place without a proper placement of e-health and health informatics, not just theoretically, but practically. Thank you once more for being at this conference. We look forward to another conference next year. But between now and then, there are activities of MEHID-Africa that will come up. We expect to have seminars, workshops, and the like. Please look out for information from us. We intend to maintain contact with you. We can't thank you enough. But just in case you have not registered, once more, we appeal to you to go online and register. It's very easy to do that. Just type MEHID-Africa on Google. Google MEHID-Africa. That will take you to a site hosted by University of Benin or University of Benin Teaching Hospital, and you can locate how to register there. Click on the provided link, and you'll be able to get into the form. Or you may have received a link before now. Simply use the link and complete the form. If you are on LinkedIn, it's also easy to get there. Just look out for MEHID-Africa on LinkedIn, and you'll see a link to the registration form. Simply register so we can have your records and we can maintain contact with you. You are the backbone of our networking. You are the continuity of this project. We rely upon you. Our relationship with you is something we will never regret. We make a promise to you also that we shall fulfill our part of it. We thank the Vice Chancellor. We thank the Chief Medical Director. We thank all the principal officers of the university and of the teaching hospital. We thank God for how he has helped us through. Africa will never remain the same again. Thank you very much for being a part of MEHID-Africa 2021. God bless you.
Full of praise.